সেইটো সেই ডাইৰেক্ট কৰাব লাগিব এইফালে WDF ৰ
দেন নালাগে নেকি কও
কোনটো
এই মাজৰ দেখো
লাগিব দেনটো পানীটো একে
এইটো ফোন একদম আমেৰিকাৰ পৰা আহিছিলে এইটো ফোন যে কৰিছিল
সজত
বলা
हाँ सही बात है सही सोच रही तू
किसको कॉल करना, मुझे नंबर नहीं है मेरे पास। वैष्णवी। इवन कर दो माइक।
Morning to one and all. We will be starting the conference shortly.
Good morning, Dr. Radha.
Good morning, sir. Very good morning to all. I think we are good to start. So we are on 99 mark now for the first session. Oh, it's 101 now. So I think this is a good time for us to start. So a very good morning to all of you. My name is Dr. Radha Balavikar. I want to check if I am clearly visible and clearly audible. Can somebody let me know?
Dr. Radha, you are very much audible and very much visible.
Great. Great. Thank you so much, Ranjana. So after a fantastic day one of this conference, Jaagar and Awakening, which is the second Northeast India Annual Diabetes Conference, organized by Strengthening NCD Services in Assam project funded by World Diabetes Foundation, which is a state-level project which Government of Assam is implementing across Assam in partnership with the Piramal Foundation. I welcome all of you to the second day of this conference. So day one was filled with rich discussions on a wide variety of topics. We got excellent feedback from all our participants. We managed to address a number of issues which are directly related to NCDs and also which are considered as social determinants of non-communicable diseases. I welcome you all to day two, and I promise you another day filled with rich discussions, interactions, and experiences from the field, which my colleagues would be sharing. At the beginning, I would like to also welcome our keynote speaker for the day, Dr. Ashok Roy, who is the Director of Regional Resource Center for Northeast. So I would request all participants to please stay muted unless you are speaking officially into the conference or you have a question to ask for which you can raise. So I take this opportunity to introduce Dr. Ashok Roy. It's my pleasure and honor to introduce Dr. Roy. So sir has done MBBS from Budwa University, West Bengal, DPH from Calcutta University. Sir has 33 years of experience working at grassroots level and also at the policy level, driving policy action in the sectors of health, socio-economic empowerment, community-based health services, and health system strengthening. Sir's journey in the health sector started in 1987. Sir has a rich experience of around 5 years in National AIDS Control Program as State Project Director of Tripura State. At present, Sir is the Director of Regional Resource Center for Northeastern States and is playing a pivotal role in health system strengthening in the Northeast region. To me personally, I think Sir has been a mentor, and every time that I speak with him, I learn something new. So welcome, Sir. I invite you to please take over. You could share your screen. You're the co-host now.
Yeah, good morning, Dr. Radha.
Good
Thank
morning,
you
sir.
very much. And that was a nice introduction, I will say. Right. So let us start the thing for today. You can share it. There's no problem. You can share the screen, my slide. So the topic is the non-communicable disease and the tribal health in any context. So,
Yes. Can I request the IT team to please share Sir's slides? Utpal? Yes.
right. Thank you. So it's a small presentation, just a little bit effort to show what is the field experience and the mixing the concept as well as the field experience to improve further. So when we talk about that, the next one, please. If we have a look, next slide. Yeah. So if we look at the map, we can see the tribal population in any state. But before going into further, I would like to say that tribal population in any state, though it's more and more, but even then, our northeastern tribals are a little bit, I will say, better off than the rest of India. Can't I have the full screen? So you will see that the highest tribal population is in Mizoram, followed by Meghalaya and Arunachal Pradesh. So the next tab, please. Yeah, so if we have a look at how the tribal population in Northeast, we must understand this tribal population, major tribes. There are so many, and also, no, earlier one, previous one, please. Yeah. You can see that particularly vulnerable tribal groups we have only in Manipur and in Tripura, that is Madam Naga, and in Tripura it is Riang population. And if you can have a look at the scheduled tribe population in Ladakh as per the census 2011 and the percentage, and also as of RHS 2021, we can all see that there is an increasing trend in the number of percentage of the tribal population against the total population, state total population. So northeastern states or the northeastern region is more or less more into the tribal-based states, but I will say that our tribals are more literate and a bit, they came in contact with the missionaries for many years, so their lifestyle and the health-seeking behaviors are a bit better. Next, please. Now, if we think about the non-communicable disease, we all know that 21.9%, nearly 22% probability of dying from any cardiovascular disease, cancer, diabetes, in between the age group of 30 to 70 years. So if we go by absolute number, approximately 17 million people die from a non-communicable disease before the age of 70. And obvious, please, previous slide. And before 70, obviously, nowadays we can call it a little bit premature. So these 86% of these premature death occurs in LMIC and MMIs, middle income group countries. And the most dangerous one is the cardiovascular disease, followed by chronic respiratory, and obviously diabetes. These four groups of the disease account for over 80% of all the premature death due to non-communicable disease, and responsible for 7 out of 10 premature deaths in 2019. And obviously, COVID-19 also added to it. Next slide. Here is an effort to show the distribution, state-wise distribution of the NCD statistics, state-wise. The first column, you can see the column in cream color is a high or very high blood sugar level or taking treatment to control diabetes. So the yellow highlighted percentages are more, you can see for yourself. I don't have to say anything. And the blue one, light blue one, is the elevated blood pressure or taking medicine for the non-hypertensive cases. And the pinkish column shows you the screening for cervical cancer. As you know that this program of screening of cervical cancer is still in very initial stage. So hopefully it will pick up some more. Can I have the next slide, please? In this slide, I have tried to show you the evolution of this program. Under the NPCDCS program, we all know that digital health profile of the population is being captured. Screening of population for 30+ population, I will say, for NCD at camp and facility level, it started vigorously. And obviously the management of the non-communicable diseases at the secondary and the tertiary level. Under our Honorable Prime Minister's initiative, this Ayushman Bharat program and other schemes, if we look from a different angle, one of the major milestone is the creation and commissioning of the health and wellness centers under comprehensive primary healthcare program with an expanded range of service. When we talk about these services, we all used to do earlier days mainly services related to reproductive and child health. But now with that addition of care for oral, eye, ENT, emergency, mental, neurological, and substance use disorders have been added. But here is the catch. Wellness activities also added. Our field activity has been strengthened by house-to-house screening for NCD using CBAC form. I'm sure we all know about CBAC. What is that? Formed by ushers and followed by screening and confirmation at the facility level. I mean to say the primary health center upwards. And one of the most important terms, as per it is envisioned, is the continuum of care. That if a particular individual has been identified to suffer from a particular non-communicable disease, then from village to the primary health center plus, and back to the village with medication, regular medication. And the health sector peripheral field level workers are supposed to keep an eye on that person, ensure the regular intake of the medicine, and for regular care. That is the most important part of it. And obviously, quality of this continuum of care service is yet to be, there is many scopes to improve. And the palliative care also part of the expanded package, 12 expanded package. Financial protection, we came with health insurance scheme under PMJY and infrastructure development, strengthening of the diagnostic network in the villages at the block headquarters, and as a integrated public health laboratory and the block public health unit are coming under PMAV. Next slide, please. That effort for infrastructure development and strengthening of the diagnostic service and the free drug initiative is an effort to reduce the out-of-pocket expenditure and availability of the diagnostic test and the drug ensure the availability of the drugs, medicines at all the level, including the health and wellness sub-center level, to reduce the out-of-pocket expenditure. Now, our northeastern regional challenges are there, as we have, because it's a difficult terrain. So service availability, HR shortage, especially the specialist. Problem is in the management of this supply chain management, including drugs and diagnostics, accessibility, a longer rainy season, and obviously topographical challenges are there. Added with behavioral aspect means limited knowledge, information, a little bit of, I will say, cultural and practices, traditional methods of healing, poor compliance, they don't want to take medicine also, and the lack of convergence and the multi-stakeholdings with the other development department, and because the amenities are in the lower side in the periphery, actually the attitude of the health service provider also have lots to improve, which all these contribute to the high dropout rates. Next, please. Now, what we try to do as a branch of National Health System Resource Center in the Northeast, and that this regional resource center for any states, it was established in 2005 to give the technical support to the northeastern states, and we are still operating with lots of faith from the states and involvement of the states. And we all know, that there is earlier there is an increase of something around 18% of total increase of the disease burden against 2019. In 2013, this has been observed. There are rapid changes in lifestyle, diet, urbanization, and among the tribal population, there is a bit of eating dry fishes, high salt intake, changes in food habits. This is seen among the larger population, especially among the tribal groups in particular. So all these habits also change the pattern of the disease. So hence, there is a change in approach of health intervention. As I have told you already, that comprehensive primary health care through functionalizing health and wellness center, till date in any states, any region, out of the targeted 7246 health and wellness centers, we are successful in establishing 7,546 as of yesterday. We try to bring the health service to the community, the common terminology that at the doorstep of the villagers and to the tribal and other marginal communities. We are trying to strengthen that. Now see, the quantitative part is over. Hence come the qualitative part, wherein we all had to work together. Strengthening the health and wellness center, we are trying to do for comprehensive and all-inclusive primary health care at the village level, which is not possible without the proactive community engagement by the village health sanitation and nutrition committees, then village-based initiative to synergy health, water and sanitation, that is called Vishwas. Plainly saying that without the proactive participation of the community, it is really, really difficult, because community has to own this effort of Government of India. And side by side, Ministry of Health and Family Welfare, Government of India had added another additional manpower or mid-level health practitioner at the HWC subcenters or the community health officer. And as I have said, in all this service, the continuum of care is the key word. And side by side, lots of innovations are happening, health research are happening, data are being generated, and these are being analyzed for midterm calculation, improvement. Now, I would like to show you some observation from the field. Say, as I have mentioned, next please, next slide. As I have already mentioned that continuum of care is the key word. You can have a look a bit minutely. Though I have written the name of the certain villages are there, which you can identify to be which state, but I don't want to mention it. You can see the family folder nicely printed, which have been supplied by the Department of Health of that particular state. But see, the guidelines, the training, all this, the success of those guidelines and the training all depends how we implement it actually in the field, how those guidelines are being translated into the field activity in the peripheral level, so that whatever the aim has been envisaged can be reached. Now here in these beautiful family folders from one of the northeastern state, you can see a red circle with three scribblings. These scribblings are for a particular family, and these scribblings belong to giving some numbers, some identification numbers, I will say, of the ASHA, given by ASHA. Then by the next step is the ASHA facilitator, and the last one was by the auxiliary nurse and midwife, ANM. It's a good quality family folder. So population enumeration is being on in that village. And next slide, please. But the thing is, what I would like to say, when you go to the field and try to see, irrespective of the state in Northeast or in Southern India, I have the opportunity to visit Southern or Northern India also as a part of the Common Review Mission undertaken by the ministry. And this is irrespective of the state. Actually, in the field level, we see these things. Wherein we go to a particular subcenter HWC and ask whether this population enumeration or screening, preliminary screening and filling up of the CVAC form, whether it is happening or not. They say yes. Then when we saying a particular name or some particular family, can you please take out this family folder for that family? Some of our field functionaries are not able to take it out from the jumble or pile of the filled-in CVAC forms, because these duly filled-in CVAC forms, which are being filled by the ASHAs after examination or further screening, is not being kept properly for easy retrieval. And it doesn't need any rocket science, honestly. It needs to be kept ASHA-wise, village-wise, and 3 identification number given by the ASHA facilitator or the ANM. is not required. And I think, which is a training issue. Now here you can see this photo, this picture, that the blood sugar level is 490 on a particular day. The date is mentioned somewhere. I think it's not, photography is not that clear. We saw this register after 6 months, after 6 months. Then we asked for their family folder. And then we tried to find out what corrective measures had been undertaken by the peripheral health functionaries, means CHO, ANM, and ASHAs. Unfortunately, nothing. The blood sugar level was, high blood sugar level was identified, a case. But after that, there was disruption of service. No continuum of care could be seen. Next, please. Here you can see a duly filled in CBAC form, part of that family folder, which shows somebody is having 6 marked, calculated as 6. And there was no follow-up. So these are the problem what we are facing. Next, please. So this peripheral staff need to be briefed once again by anybody. It's not a rocket science. It's use of common sense only, and which a medical officer, a proactive medical officer of a primary health center, or the district health officials, responsible officials, can undertake this. The peripheral field staff need to be reoriented and to be seen, supportive supervision, to need to be seen what they are doing, where the mistakes are being happening, and correct it. The tracking of a family or the family folder is not happening. Regular follow-up and continuum of care need to be improved in true sense, especially the continuum of care. Hence, the peripheral staff should be aware what is meant by continuum of care or continuity of care. That concept is yet to sink in true sense. Earlier we can help in this. I'm sure our NCD screening and implementation of the this NPC-DCS program or the non-communicable disease program, along with comprehensive primary healthcare package, all are going to improve, and our health-seeking behavior also will improve. Next slide, please. So that's all from my side, because the onus of implementation is on us. It is our responsibility to brief, to train, to counsel our health functionaries that how the government policies are being implemented and how to improve the quality. Thank you very much.
Thank you so much, sir. It is said that the simplest things are often the hardest ones. And what you have spoken about essentially captures that of how really simple changes, process changes, and attitude changes can actually lead to big difference, especially for people who are a part of the system and people seeking care for non-communicable. I would request the participants to please stay muted. Thank you. So with this, we open for questions for Sir. Sir has beautifully captured programmatic components related to non-communicable diseases and also given us snapshots from the field common errors from the field, constraints from the field. So we are open for questions, and I see one hand raised already from Dr. Rajendra Prasad, sir. Yes, sir, over to you.
Am I audible?
Yes, sir.
Yes, please.
Good morning, Dr. Shukra and others. I am also
Morning.
an aged and experienced senior public health practitioner for the last 40 years. Started my career of first 5 years in tribal area, then switched over to urban areas. Still continue to work with Pyramid Swasthya as one of the consultants. So your simple presentation has been very, very direct, straight, and valuable in my perspective.
Thank you, sir.
At the highest level of policy making, it is very efficiently designed and carefully structured, and the program is released onto the ground. But at the grassroots level, key mistake, key lapses, for whatever reason it might be behind it, they affect it to a major extent. Without meaning or sounding any animosity or any hard lines to these things, you have in an objective manner identified these things. That's good. I have two observations to make with the NCD's incidents in the Northeast. My exposure to Northeast is only limited to Assam, which I visited 2 times, and that too short. I have basically been from South India, and my observations are: number one, the service delivery mode in case of non-communicable diseases should gradually transit itself into service management role. By saying that thing, I mean the responsibility and participation of the recipients of the service should be heightened, particularly in northern states. The logic I have in my mind is they are relatively more educated, they're expected to be more conscious and aware of these things, and their responsibility should be there. Yesterday's presentation was repeatedly emphasizing one point, that in the case of NCDs, the care is going to be lifelong. The medication, if it is started, it has to be made lifelong. See, another person from the service delivery chain taking care of a beneficiary for lifelong is always going to be a challenge. So, in my expectation, in the course of time, gradually the percentage of responsibility to be assumed by the actual beneficiaries should be raised. And that is very much possible in Northeast states. Second thing is, as you rightly pointed out, the mistakes being committed in NBAC filling and not failing to raise the rate flags when high figures are shown there, risky figures, and failure for non-follow, these things. I think the responsibility should be more laid with the supervisory cadre. ASHAs have now been provided with ASHA supervisors and facilitators. ANMs have got their supervisors. And unfortunately, in my service career and afterwards also, my personal observation has been supervisory cadre has consistently failed to live up to its responsibility level, etc. That has to be strengthened. With these two things, I stop here, applauding the direct, straight, and I don't call it hard hitting, very valuable pointing presentation of yours. Thank you.
Thank you, sir. As you have already mentioned that the improvement in the supportive supervision is the key to this midway correction of this field activities is a key thing, and truly said. And somehow over the years of a decade, I will say, starting from our medical officer level at the primary health center, PAC medical officer or up, and then to the supervisory cadre like multipurpose supervisor, ASHA supervisor, somehow the quality is highly compromised, or we are not able to push them actually what they are supposed to do and less monitored.
Yeah.
That's my submission.
If you permit me, I would like to touch another point, which will be of really good interest to other participants also. The national announcement says As of 11th January, out of the expected 1.5 lakhs of upgradations of health and wellness centers, sub-center level health and wellness centers, 1,17,000, PSCs, health and wellness centers, 23,000.23.5 thousand, UPSCs nearly 4,800, Ayush 6,700, urban health welfare centers 2.5. Out of these things, your regional data, I remember you showing in one of the slides that out of 7,500 or so, 7,200, etc., have already been upgraded. Am I right?
Yes, sir.
So if they are really upgraded, not on paper, but on ground, with inclusion of extra manpower, supply of extra equipment, and adequate trainings, they must take up immediately. And in a course of 2 to 3 years, visible, conspicuous results are to be expected. Because there, the palliative care comes in, and the oral screening comes in, which takes care of oral cancers. And palliative care will be touching indirectly the tail end part of the cancer care. And CBSE will get strengthened. And CHO role would be very much beneficial, both as mentor, facilitator, and supportive enabler for these ASHAs in these centers. So I only hope from this distance, I'm speaking from Hyderabad, that these 7,200 odd upgraded subcenters as are being claimed are really functional and they are going to be effective. That's only my wish. Thank you. I will stop here.
Right, sir. One thing I just need to add, to be a bit more cautious in actual thing, what is happening in the field, as I told you already, these numbers are achieved figuratively. Now, our main challenge, as you know, that health is a state subject, state has to do up to the level of the district trainers, they are trained also in the expanded package. But this cadre now need to train the actual implementer in the field. And in a cascade level training, there are certain loss in transmission. That is also there. So the main effort is to push the training now and to ensure the increasing the package of service to 12 package. Few sub-centers are still doing the cervical, say, screening, cancer, and other things. Few of the expanded, but not in uniform throughout the northeastern states. Trainings are happening. They need to take up the pace. And I'm sure once these are done, then obviously with the increased field visit, we all, with the help of the state health machineries, will be able to improve the quality of service as well. Thank you.
Thank you so much, sir. I have received one more question, so I will pose it to you, and this will probably be the last question. The question is, can digitalization of health records improve continuum of care in the Northeast region?
Digitalization of the health records obviously will improve, but it's not related with the health department thing, the space at which the digitalization accessibility to all those internet, and these are yet to be, I will say, I better not comment on this, you know better than me. Actually, say if we all are working in the health sector, for how many years we are listening to the word BharatNet, BharatNet? This is number one example. Second example, this is our country. Without any pun intended, 35 years ago, we used to hear that public health cadre, public health cadre. After 35, 40 years, what we are successful in it, we added another word to it, that is public health management cadre. So we can jolly well understand the pace of implementation actually truly in the field. Obviously, situation has improved a lot, and we need more faster connections and all. Obviously, digitization will be very, very helpful with something like an UID, so that we talk about AVA ID. AVA ID, I'm sure that is Ayushman Bharat Health Account. If we all have this number at least, then our profile, our health profile can be ported to anywhere. That is the main advantage. Otherwise, we have to carry our documents in kind. Paperwork, paper leke chalna padega sab file mein. The file in a plastic carry bag. That is what the usual thing which we see generally visiting while in a hospital. Thank you very much.
Thank you, sir. Thank you so much. So on behalf of the organization and from the organizing committee of the conference, I thank you for your valuable insights. Very good points that you raised from a program perspective, from a policy perspective, from your on-ground experience. I think it was a very comprehensive, very rich and very enlightening session. I thank you for your time once again, sir. And please wait back with us for the remaining sessions. Thank you so much.
Thank you very much.
Thank you, sir. So with this, I now hand over to my colleague Latashri for the next session. Thank you.
Thank you, Radha ma'am, for giving me this opportunity. So, a very good morning to everyone. I am Latashri Bora, District Coordinator of Lakhimpur District under the project Strengthening NCD Services in Assam. So, I welcome you all to the second day of second Northeast India Annual Diabetes Conference. So, now we have a guest of honor, Dr. Sobhayaka ma'am. Ma'am is working as a Vice President, Tribal Health Collaborative, Piramal Foundation. Ma'am, also ma'am is a healthcare professional with extensive and in-depth experience of strategic planning, project management, capacity building, private sector engagement, institutional and multi-sectoral partnership and stakeholder management. Her expertise lies in building sustainable public-private partnership in public health domain. She has worked in various capacities with organizations like Foundation of Innovative New Diagnostic, KHPT, IHAT, HLFPPT, and now working in Piramal Foundation. So I request ma'am to kindly give a brief introduction about Anamaya project. Now I hand over the platform to Dr. Sobhayaka ma'am. Ma'am, over to you. Thank you.
Thank you, Latashri, for that introduction. And a tough act to follow, Dr. Ashok Roy, sir, but I will try to do justice. Two things also I would like to add to what Latashri has said, which I take a lot of pride in, is that I'm an ex-army, I'm an ex-major, so having served in the army, and my posting, most of my posting has been Assam. So therefore, the context is so much more important to me today. Also, the fact that I also come from a tribal community of Jharkhand, and doubly so, the importance of being part of this conference. Thank you, Radha, for giving me this opportunity. Can we then move on to our presentation on Anamaya? I'll share my screen, so maybe please let me know once you can see that. Can you see my screen?
Yes, ma'am, we can
Yes,
see you.
ma'am. Yes, ma'am. We can see.
Right. So Anamaya stands for free from sickness. It is a Sanskrit word meaning free from sickness. And this is what we call the Tribal Health Collaborative in Piramal Swasthya. The little bit background with regard to Tribal Health Collaborative in the sense of how it originated is something I would like to tell you about, though I was not part of it, but just the program started in 2011 in Araku Valley, wherein the solutioning for safe delivery for tribal women in the Araku Valley was started. Basically, it was in relation to increasing the institutional deliveries amongst tribal women of Araku Valley. And between 2011 to now, the institutional delivery has reached from 18% then to almost about 85 to 90% now. And with great pride, I would like to say that just before COVID, actually sometime in 2019, there were no maternal deaths reported because of the interventions that were taken in this program or project. That is how the need, the learnings and insights from that project showed that there is a felt need for working amongst tribal communities, considering the fact that there are multiplicity of health issues related to the diversity of geographical areas that they live in, and the complexity of problems that are arising, that have been there and that have been arising in the recent past. So therefore, Tribal Health Collaborative came into being under Piramal Swasthya. My slide is not moving, just give me a second. Yes. So we'll go through this presentation under these headings: Tribal Population in India, an overview, which I will go through very quickly. What is the status of health among tribal population? Tribal Health Collaborative, its goal and strategy. The strategy including the 3 pillars of communitization, strengthening public health systems, strengthening knowledge and informing tribal health agenda. We'll come to some disease-specific interventions that we have under the collaborative, particularly Tribal TB initiative. The other 2 being Saksham and WDF, which are already being discussed. So I will delve more on the Tribal TB program, and then a small snapshot of the achievement thus far. So this is an overview. I think all of you have been seeing this since yesterday, but still, just to iterate that there are more than 700 unique tribal communities in India, including the PVTGs, speaking over 300 languages. So that's the kind of diversity. And this population lives across almost 177 notified scheduled districts across India. Mostly, or 90% of them residing in rural areas where 60% of the country's forest coverage is present. So that is the kind of spread that we see with the tribal communities. And therefore, the solutioning of one size will not fit all. That stands very true to the tribal communities and tribal geographies. One very important aspect that we need to keep in mind, that this community is the keeper of traditional knowledge and wisdom, as more and more the global world is realizing and going back to, wherein we are coming with the understanding that these are the communities that live very closely in sync with nature, how they preserve nature even though they live off it. So therefore, the wisdom of living with nature and preserving nature, the problem of climate change that we are seeing now, can we derive some wisdom out of that? Having said that, there is still the issue of multiple health issues among tribal population, some of them as basic as malarial deaths, death during childbirth, tuberculosis, malnutrition. And as Radha had mentioned, the risk factors are multiple and so much more deeper in terms of social, economic deprivation. Recently, what we are witnessing is displacement from forest and land, which is depriving them of their source of livelihood, forest produce, and pushing them deeper and deeper into malnutrition and related issues. Add to that the stigma and discrimination and low literacy. What we see is such low level of sensitivity amongst the healthcare providers and the health system for these communities. So one of the things that Dr. Ashok Roy and even Dr. Rajendra before me mentioned was how to look at continuum of care for these communities. Without that, the possibility of having to deal with their health issues looks very difficult. Therefore, Anamaya, a multi-stakeholder collaborative, is committed to end preventable deaths among tribal and other marginalized communities across India. And it will strive to improve the health outcomes for the 101 and 104 million tribal people, and to help India achieve its SDG 2 and 3 goals. And the SDG 2 and 3 goals are the simplest and yet the most difficult, where we are looking at bringing in zero hunger and good health and well-being for all. How do we think we are going to achieve this? This slide looks crowded, but just to simplify for you, taking cue from what, again, my predecessors have spoken in terms of looking at a holistic solution and catering to the continuum of care. What has made my presentation easier is that Dr. Rajendra and Dr. Ashok both have mentioned the involvement of the community. So that is the basic ingredient that has to go into co-creating health solutions for these communities. They need to take the ownership, they need to take the responsibility, and that has to be built in what we call in our program as communitization. So we are looking at using some of the key channels from amongst the communities to build their capacities, to build an agency amongst themselves, that they are able to speak up for their health needs, recognize their health needs, and demand for their health needs with the healthcare, from the healthcare system. Once the demand side of the health needs is catered to, the supply side also needs to be strengthened, and therefore strengthening public health systems also is a very integral part of the strategy of Anamaya. Though we have very recently forayed into this, and we are at present only at the point of diagnostics or gap analysis of the systems. Coming to that later on in the slide, much of it has been discussed by Dr. Ashok very lucidly. So I might actually, it will be very easy for me to go through that. To be able to work on these two pillars, what is very important in the context of tribal communities is informing the tribal health agenda by strengthening knowledge. The fact that there are 700 tribes across 174 districts requires our collaborative or even the wider health service delivery to understand these communities, to understand the culture of these communities, to understand their health seeking behavior. only then will we be able to, sort of build up on that knowledge and learnings to be able to look at how to communitize them and how to provide the strengthen the service delivery for them. Coming to communitization, some of the key objectives, I will not go through all, but majorly is how do you prioritize health and nutrition as an agenda within the community, improve their health seeking behavior, and build agency amongst the communities that they are able to elevate their voices for their health needs. This also, one of the objectives is also to inform the public health system. Building future leadership from amongst the community is one of the sustainable ways in which we can bring forth their positive change in their health seeking behavior. Last but not the least, enabling transparent and compassionate communication between the public health system and the community. The fact that these communities, there is suboptimal trust amongst these communities for the public health system, as we have seen, and therefore there needs to be a compassionate communication between the two. What we have found and would like to work with are the 4 key channels to be able to bring about these changes. One of the very important channel that everybody knows and is being spoken of these days is leveraging the tribal traditional healers network. These being the first point of contact for the tribal communities, more than the public health system. This is an opportunity for the system to be able to provide this last mile healthcare services inside of these communities. So therefore, there is a need to understand their practices. Presently, there is a lot of work going on with regard to codifying and certifying the traditional healing practices. And even WHO recognizes that it needs to be certified to a certain extent. In Jamnagar, Gujarat, what we have now is a global center for traditional healing practices. So that is the kind of commitment that we are seeing and the momentum that we are seeing. And therefore, it gives us hope that if we use this channel optimally, we will be able to reach out to these communities in a much at larger scale and in the way that we want to see it. The other channels being tribal self-help groups and PRI members, who are the point of connect with the system for these communities. They are the holders of power, and therefore decision making lies at their level. If they are the community influencers and can be trained to understand the need for being the voice of their communities, we will be able to move the needle of health indicators so much more faster amongst these communities. Tribal youth groups and student forums, like I said earlier, raising them as leaders to bring up the voices of the communities, and the tribal NGOs and CBO forums, which are the instruments of bringing these services to the communities. So therefore, at present, we are looking at these 4 channels. Definitely, there are others. And as we said, that the knowledge that we are hoping to gain through research and other projects of ours will help us to leverage these and other channels much more better. Coming to the public health system, I don't think I will be able to add more than what has been said and emphasized already, that the public healthcare system has to gear up to be able to cater to this hard to reach population. At present in the collaborative, we are looking at the diagnostics, and we have been able to map some of these issues in a couple of states, particularly Chhattisgarh. I would like to draw your attention to a couple of these issues that we identified. One of them was that though there is this 92% information which is obtained from the Mitanin by tribal women, only 8% of these, 6% of these tribal women avail health services. And just about 8% of the community members have knowledge of the government schemes. So that is the level of knowledge in terms of health in these communities. Apart from that, the usual gaps in the health service delivery have been encountered. We have recorded system and governance gaps, particularly drawing your attention to 66% facilities in the region, especially Chhattisgarh, having gaps in financial accounts. So therefore, some of the interventions that are being planned are in the realm of digital transformation. So this also, there was a question with regard to digital, whether digitization is going to help health system delivery. It is going to help, but yes, the question lies with the operationalization of this transformation. As usual, here also there is this problem of recording of data, which is at the field level, and therefore there needs to be some form of digital transformation in that data pipeline as well. The technical and the health tech systems, integration of those systems and making them NDHM compliance is also being seen as part of the strengthening process that needs to happen. Institutional capacity needs to be built. So therefore, we are looking at staff availability, their capacity building, administrative reforms. So not just financial reforms as is mentioned here, but also looking at the soft skill reforms or building to basically cater to the sensitivity of the staff for these population. Review and monitoring system, as was mentioned earlier, also needs a lot of strengthening, right from data capture to service delivery and outcome reporting. Last but not the least, the service delivery channels need to be strengthened in terms of facility management, in terms of quality assurance, last mile delivery, and frontline worker strengthening. We have yet not forayed into most of these, except for some part of the capacity building of frontline workers as well as the administrative staff, which I will showcase later. Coming to strengthening the knowledge and informing tribal health agenda, definitely we are looking at research to generate new evidence and insights. We are looking at learning from the different programs and partners of Tribal Health Collaborative, and this particular conference that is happening has been a huge learning experience for our entire team and me in terms of what are the needs of the Northeast and Assam, how to move forward. And I think we definitely see a opportunity to collaborate so much more closely in this direction. The MNE, of course, forming the backbone and dissemination of information. The goal is to prioritize tribal health in an equitable manner. So that's how the knowledge portfolio will work. Some of the partnerships that we are already having in place or are working with is listed here. I'll not go through all, but just for information's sake, and we hope to add more to this list. Some of the disease-specific interventions that we are doing, Tribal TB Initiative funded by USAID. We started our work in 174 tribal districts. In the year 2 of this project, we are moving into a different version of the initiative, and therefore will be working in 75 identified tribal districts this year for the TB-free status. Suction is another, which is the MNCH Momentum Accelerator, again funded by USAID in 3 states, which is Chhattisgarh, Odisha, and Assam. The speaker coming next to me will be speaking on suction. Strengthening NCD services in Assam, WDF, now all of you are aware of. Briefly on Tribal TB Initiative. This was an initiative launched on 26th of March 2021, jointly by Minister of Health and Family Welfare and the Minister of Tribal Affairs. So this, with the goal of reducing incidence of TB and death due to TB in the tribal population. A joint action plan for TB elimination was also formulated and released between the MOHFW and the MOTA, and Piramal Foundation has been the implementing agency for this plan. The first year of Tribal TB Initiative, we conducted the Ashwasan campaign, and this campaign was an active case finding campaign for TB and COVID awareness and addressing vaccine hesitancy. So there were those active case finding was carried out in 174 districts across the country. Each district conducted this over a 100-day period. We closed this activity. Sorry. We closed this activity sometime around September, and these are the highlights. From January up until August, we covered 174 districts, 1,122 blocks, and inclusive of 68,000 plus villages. We had employed some 2,240 staff apart from the government staff. We had also used some 650 plus vans with drivers and 460 bikes to be able to reach the hard to reach areas. The highlight of this campaign was the population that we were able to cover in terms of IEC. So as you can see, we could reach 1,66 lakh plus people in these 68,000 villages, of which more than 1 crore were screened for symptoms of TB, which is not a mean feat considering just about 8 months of work, wherein most of these 2,000 odd staff were new to the program. We were able to collect samples for 2,80,000 people from amongst the 3,80,000 plus presumptive TB cases found. And we were able to find, of the tested, diagnosed TB patients were 10,249, which is about 3.7% of the tested. This has been widely acknowledged now as a very successful campaign, as opposed to the active case finding that regularly happens in the NTP program. It contributed to about 13% overall from all the states combined during the period that it was conducted. A learning dissemination conclave of this event, of this campaign happened in August 22, where JS MOTA and JS Ministry of Health presided. The Ashwasan process document has now been uploaded on TBC India website. All of you can please have a look at it. Honorable President of India also acknowledged the campaign during her address at the Prime Minister TB Mukt Bharat Abhiyan launch in September. and Ministry of Tribal Affairs thereafter reaffirmed their commitment during a multi-sectoral engagement conference in October 22. So the commitment has been ongoing and Piramal Foundation is committed towards this initiative. The learnings and insights, one very important aspect that came out was places where we engaged with, where we took in staff from amongst the community mobilizers and paramedics were the places where we were able to work best. And therefore, it has been a learning that if we have to work with these communities in these geographies, it is imperative that we employ staff from these communities to work inside those geographies. It is again to reiterate that community influences at the village level have to be involved for a community response, without which it will not be possible to build that ownership or change the health-seeking behavior. A 100-day campaign is the optimal time, or 3-month basically is the optimal time to conduct such campaigns in a certain geography, as opposed to the 2-week ACF campaigns that happen in the program. So that is something that the Central TB Division has also taken note of. Sample collection and transportation is a very important mechanism that needs to be put in place for this program, which is one of the major gaps that has been seen, whether it is passive case finding or active case finding. So therefore, a lot of emphasis and measures are being taken now and in the PIP of the districts and TB program of the TB of the NTP program. Now provisioning for sample collection and transportation is becoming an important line item. X-ray facilities suboptimal, and therefore the need for establishing X-rays at block level is that much more important. In Assam, I just want to show you some numbers. 31 blocks with 7 districts, 4 lakh. Yes, Radha, I will just finish it in 2 minutes more. These are the numbers for Assam and for Northeast. Northeast, we were able to cover 7 states with 641 diagnosed of the 73,000 tested. So these are some of the snapshots which I have already mentioned earlier. Thank you so much for your patient listening.
Thank you, ma'am, for giving your valuable time to us. And really, this was an excellent presentation. We have got lots of knowledge about various programs under Anamaya. So thank you so much. Now I open for question. If anyone have any question, please ask, ma'am.
Yeah, I think Dr. Shobha will also be here with us for some more time. So the questions can come in the chat as well. But I think in the interest of time, we can also proceed and we may go to the next speaker. Meanwhile, I would encourage questions. I would encourage discussion and let the comments and questions keep coming in the chat, guys. Thank you.
Okay, ma'am. So now may I request my colleague Priyanki Datta to continue the next session.
Thank you.
Hello, everyone. Am I audible to everyone?
Yes, Priyanki. Yes, you are audible.
Okay, thank you. Thank you, Latashri, for giving me this platform. And also thank you, Sobha ma'am, for beautiful presentation. So now we can move to our next presenter, Mr. Smith Singh. So I welcome, sir. Mr. Smith Singh have had a successful holistic career in a span of 20 years across some of the leading MNCs and strong bonds. He and marketing at heart with a specialization in sales distribution, and supermarketing, and with vast stint in these roles. He has been leading organization to a strong growth pattern. So here we are welcoming you, sir, and I invite you to please take over the session and you can share your screen.
Thank you. Is my screen visible?
Yes, sir, it's visible.
Okay, thank you very much for the opportunity. And let me just do the screen show here. Thank you very much for the opportunity. And I'd like to introduce myself. My name is Ishmeet Singh. As Vinka said, that I've fairly joined the Pyramid Swasthya a couple of years back, and it's been a very interesting journey for me. I'm sorry for the background noise. I'm actually outside, and there seems to be a Republic Day celebrations happening here, preparations happening in Delhi. So sorry for this, but I'll hopefully take only 10 minutes. The part of the organization I represent is Digital Bharat Collaborative, which is really about focusing on the digital initiatives and building state capacity in digital transformation projects. Our focus is to promote nationwide digitizations through key initiatives that support the state in achieving its digital goals. And the domains which we focus are really the following as of now: continuum of care, where it's really about enhancing service deliveries to citizens through the public health facilities, lower and higher health facilities. Data-driven governance, and I am sorry again, the background noise. Data-driven governance about implementing a unified data source and ensuring that we promote and support the state to take database decision making. I know the background noise is too much. Maybe I'll move inside.
Ishmeet, you are not audible.
Yes, I'm sorry. I just moved inside to avoid the noise outside. I hope this is better.
Yes.
Thank you. So the third area which we are focusing on is building state capacities in the area of digital. How do we help them do the visioning, contracting, finding all the system gap, and doing change management for their digital transformation projects? As you see below each of the areas, we've mentioned specific projects which we are supporting the states on. And last but not the least is community outreach, where we are actually providing healthcare services in partnership with the local governments into the marginalized communities, especially through health information helplines and mobile medical units. And of course, we undertake diagnostic and research to test new concepts, innovations, and demonstration through pilot projects. Especially in Assam and Northeast, we've been very active for the last 10 years on various projects. I'll just give you a highlight of a few of them. Mobile medical units is a big project which the state of government of Assam runs along with us. 87 of these mobile medical units are running across Assam, providing medical equipment, diagnostic services, and also drug supplies to the local communities, especially to the communities which are not connected or not accessible with the nearest health facilities and the remote areas. These mobile medical units are equipped with paramedics, doctors, in some cases doctors as well, but to help them with various types of help the communities connect with primary healthcare services. We've also tried various value additions in these mobile medical units, providing them telemedicine services. We are using an in-house application called Amrit, which is NDHM compliant, and actually offering the services of universal health ID, data standardization, and also creating electronic health records for the patients. At the same time, we've also tried some innovative, courtesy our partners like WDF. We've also tried screening for diabetes through latest AI-enabled technologies. Diabetes retinopathy and neuropathy have been tried in a few mobile medical units, and hopefully we should be able to scale it up soon. In the last 10 years, over 46.9 lakh citizens of Assam have been touched and recorded through these mobile medical units. And of course, screenings for various NCD and other diseases have been done across these years with the citizens there. Coming to the other service we provide in Assam, which is the 104 Health Information Helpline called Sarthi. It was inaugurated almost more than 10 years back, and since then it's been very actively running, providing various kinds of services to the citizens, available 24/7, 365 days a year, and actually again running on Amrit, supporting the citizens who are calling in with a clinical decision support system. We also have doctors and mental health specialists available for counseling if required in these health information helpline. Over 18 million people have been touched by these services over the last 10-15 years. And again, a very popular service with the citizens of Assam, which has been provided in partnership with the government of Assam. The third call center, which we sort of recently started a few years back, was about the early childhood development call center, which is really focused on the first 1,000 days of the child. Where the follow-up is done with pregnant mothers for ANC, PNC checkups. Services are provided in multiple languages. The data is taken as per the government records on the RCH portal. And over 16 calls are currently being made across to the pregnant mothers, offering them various kinds of advice, education, and support services to link them to their journey through pregnancy as well as postnatal care. So through these three kinds of services, we are currently running the outreach programs in Assam in collaboration with the government of Assam on Amrit, and therefore creating electronic health records. And as Dr. Shobha said, recording every case history of the patient as well on the system. In order to take our continuum of care objectives further, we've also done a project pilot Nirmaya, which is in association with Cisco in 3 districts of Bihar, of Assam, where we are focusing on actually demonstrating a field worker application for the ASHA workers, deployment of Amrit in the health and wellness centers and primary healthcare centers, and also deploying many point of care devices, which actually takes the diagnosis to the last mile and helps the health and wellness center provide actually diagnostic services to the communities there, and therefore ensuring that the primary healthcare services, which are supposed to be available both with the ASHA workers and with the ANMs and the CHOs in the health and wellness centers, can be improved as well as recorded on a digital health platform like Amrit. This demonstration has shown various aspects. We've got great learnings from this demonstration, and we are hoping we will be able to work with the state to scale up this digitization across all the health and wellness centers and public health facilities in Assam. The current deployment in Assam actually had 4 elements to it: an Utprerna application for the frontline health workers, Amrit OPD application for 25 health and wellness centers in 3 districts, point of care testing devices of health CHO to the community members coming into the HWC system, and all of them. Yes.
Sorry, we just lost your voice for a moment.
Okay. Am I audible now?
Yeah, you are.
Yeah. So all of this is connected through a common digital platform called Amrit, where we are able to record and create electronic health records for the patient in compliance to the ABDM, Ayushman Bharat Digital Mission, and the Universal Health ID and the Aadhaar account. It's a great way to demonstrate how digital health platforms can actually support a continuum of care to the patients. Again, the scope of services across all the three areas were demonstrated here. And as I think Dr. Shobha also said, this becomes a very critical part in the last mile if you need to provide healthcare services to the community. I think strengthening through technology the last mile public healthcare facility, whether it's a health and wellness center or a mobile medical units, or the ASHA workers who are able to connect with the community, becomes extremely important. The outcome of this pilot has been very successful, and both in terms of supporting the local communities, identifying high-risk pregnancy cases, providing last mile diagnosis through the point of care devices, and of course, providing the required capabilities to the ASHA workers and CHOs to be able to do those tests and also provide telemedicine services. The way forward for us is really to work with the government of Assam with the demonstration pilot, help them put together a vision and plan for scaling up across all health facilities in Assam, and hopefully make it much more effective. And therefore, the vision is to actually have a comprehensive architecture connecting all the primary care, secondary care, and tertiary care facilities to a central hub, and also integrating all the multiple applications so that which are all ABDM compliant, so that we can create electronic health record supporting the state to be able to provide continuum of care to the citizens, and also doing any kind of disease surveillance for the at a population level. Thank you very much. If you have any questions, I would request you to put it in chat, and I'll be most happy to respond to them. Thank you very much, Dr. Radha, for the opportunity.
Presentation. Is there any questions or any comments? So if you have any questions or comments, you can write in the chat box. So now I'd like to request Latashree to take this platform.
Thank you, Priyanki. Now, as we are talking now, someone or other is sipping their cup of tea. So the tea plays as an antidote to refresh ourselves. The tea which we drink come from the tea gardens, and Assam is the highest producer of tea. Many of workers are engaged in the tea gardens, and from planting to plucking. Though their health is a prime concern, the health sector in the tea estate are scarce of medicine and basic health facility at time. For this, Piramal Swastha has a project named Saksam, which is working tirelessly in the tea state of Assam. So now I introduce Mr. Gaurinandan Sarkia sir. The Gauri sir has over 17 years experience of working in public health, more than a decade of working experience in National AIDS Control Organization, National Technical Support Unit, etc. Lead elimination of mother to child transmission program in 4 North Eastern states. Lead aspirational district transformation in Assam. Currently, sir is working leading Saksham MNCH intervention in Tea Garden, Assam. So therefore, I request sir to take over the platform and enlighten us. Thank you.
Thank you, Latashri, for the introduction. So I will just quickly share my screen. Let me know if it is visible.
Okay, sir.
Is it visible now?
Yeah, sir, it is visible.
Okay, so as Latashri has mentioned, I will talk about our Saksham program. So Dr. Shobha has already mentioned about the strategy of THC. So we are a part of THC. So I won't touch upon the strategy part. I will talk more from my experience in the field. And as Latashri has also mentioned, the tea garden has a unique challenge, poses a unique challenge in the entire health ecosystem. So we will try to address those. So when we say tea garden, it's always important. And when we when we design a solution for these issues that is being faced by this tea garden community, it is always important to understand the background. It is always important to understand the roots of these causes. So, I mean, this is bit heavy, I understand. So, I will try to make it very simple. So tea has a very long history. It all started with China, where China had a monopoly in the entire tea trade all across the world. And by 17th century, the Britishers, the tea drinking has very popular in Britain, and then they started looking for an alternative for China. So at the same time, between 17th century to 18th century, there were three things that was happening parallel.
Gauri, sorry to interrupt. I think your slides are not in slideshow mode and they're not moving also.
I think my network is a little poor here. Can you see my screen now?
Yeah, your screen is visible. Yes, now it is. Now we are seeing boxes. Could you please go in slideshow mode?
Yeah, it is on slideshow actually. Is it?
No, it's not in slideshow mode. It is showing in the regular mode. Maybe you can stop sharing, open the slides and start sharing again.
Okay, give me a moment. Is it visible now, Radha?
But not in slideshow.
I'm not sure. Okay, so it seems it's network is little poor here.
Text is not visible, but I think you can talk and explain and show the pictures. That should be fine.
Okay, all right. So yeah, so as I said, it all started in 17th century, and the Britishers started looking for an alternative. At the same time, there were a few things happening, all together. So in 1823, the tea was actually discovered. Though tea was discovered, it was the initial part was little struggle for a company, as well as in terms of commercial tea production. It did not happen very immediately. A lot of things has happened in between. Our tea seeds actually failed the sample test, and there were many tea seeds were smuggled from China, which again was a disaster. It didn't work. So if you I'm so sorry, there's some technical problem here. Anyways, so if you look at the cultivation actually started by 1839, 1840, 1838, 1839, and then the shipping has started. If we talk about the commercial production has started in 1840. So this particular phase is very important in terms of what we are talking about today, because we had shortage of laborers here. The cost was very high. So the company had to hire or had to bring laborers from outside Assam. So a lot of us already know that in 1840s, in the Chota Nagpur area, which comprises of present days Chhattisgarh, Jharkhand area, there was a revolt against the British Empire, and it gave the Britishers an opportunity to actually bring these people from there to work in the tea garden areas, right? So they have started, bringing people from there, and in batches they have started bringing the people to Assam. And it's not about how many people they brought, but how the way of bringing them. They have been brought in through the waterways, and the condition, the vessels that was used for bringing them was, it was very unhygienic. It was not human friendly. So everything started there. During this migration itself from this Chota Nagpur area to Assam, a lot of people died actually. So if you talk about the Plantation Labor Act, which came into existence in 1951 for mostly for these tea coffee plantations, and it had provisions for health, welfare for the tea garden community or for the community who works within these plantations. But that did not get implemented, right? There was one phase where actually this bringing people from outside was structured or legalized through a workman's bridge contract in 1859. So all these things were happening together. So since 1859, the recruitment has started, it took off actually. A lot of people in thousands were started coming to Assam, and most of them were forcefully brought to Assam, right? Till 1989, the tea gardens could not appoint a medical officer. It was only after this, verified medical school, which was set up in Dibrugarh, the tea gardens have started appointing a doctor in the tea garden areas, right? So that was about, what had happened till 1980s. So if we look at the current progress, in 2007-8, Assam government has started a public-private partnership with Assam Tea Gardens. So just to make the healthcare services available for all the employees. Then in 2017, the MMU services started in the tea gardens. In 2017, again, there was one, waste compensation scheme which was launched. Again, having said that, waste compensation scheme uptake, if you look at in 2022, just before Saksham started, it was very, very low. One important thing that it's worth mentioning here is that 6th schedule status for this tea tribe population is still pending, which was tabled in 2019. And in 2023, actually, if you look at in 1823, we have discovered tea in Assam. The Robert Bruce discovered tea in Assam, and now we have completed almost 200 years. So between these 200 years, actually, if you look at, not much has changed. We have a lot of government schemes, a lot of government provisions for this tea garden population. But if you look at the uptake, if you look at the implementation level, it's really poor. So just quickly about the total 3 tea gardens and small tea gardens, 1,22,000 tea gardens as per the records. So we are talking about almost 25 to 30% of the total population of the entire state. So I just quickly tried to put, since I was supposed to talk about the women, tribal women in tea garden areas and how we are making them saksham. So these are the major issues that they are actually, working with at this point of time. I don't think I have much time to explain each one of this, but we all understand when we say early marriage, it's little difficult from some of the parts towards Lower Assam, little different from some of the parts in Lower Assam. Early marriage here is the norms. If you look at the tea garden community, getting married at an early stage for both male and female is a norms here. And that leads to early pregnancy, and the entire system now, what you call the journey gets little compromised here. So apart from that, high salt intake, as we all know in tea garden, is a big issue, which also leads to some of the NCDs. Substance abuse is one big issue. Low nutrition, poor health infrastructure, inflexible leave policies. So we, as Saptam, we tried to address all this through a consortium that includes PATH, Piramal, Japaigo, and Deloitte. So PATH mostly takes care of the innovation part, where we are trying to bring in a lot of innovations around health service delivery. Japaigo is mostly into the capacity building of healthcare providers and frontline workers. Deloitte is providing us with dashboard solutions. And Piramal, as we know that we have expertise in dealing with community, so we are into the community process. So we are working on 3 basic result areas, but Assam, we are focusing on the third part, where we say talk about cross-sectoral collaboration in the tea garden areas.
Rinandan, again, I'm very sorry to interrupt you, but we are not seeing the slides move. So if you could sort of manually change the slides.
Can you see it now, Radha?
Yes, yes. We are in living lab approach.
Yeah, so I'll put it this way. I think when I'm showing it, putting it in slide presentation mode, it's not moving.
Yeah, you can just change the slides manually and you would have another maybe 2 to 3 minutes, please. Thank you.
Sure. So I will finish here. I will end on this slide. So I will just talk about what are the activities currently we are, taking up at the tea garden areas. I won't talk about our partners because I will need more time for that. So living lab approach, where we are, consulting with the community, the frontline workers from the tea garden areas to understand their problem and also to design their solutions. I have spoken about waste compensation scheme. Uptake was really low, so we have come up with a model in discussion with this community called model. So model is the whole that has been used by tea garden community. So we have named it after this model. And now if you look at where we have piloted this program, the uptake of waste compensation scheme has gone up to 85% from which was earlier 35%. Active community participation, as I have already mentioned, we are working with the youth groups, and Dr. Shobha has also mentioned about our strategy. So in alignment with that strategy, we are working with the youth groups, the SHGs, the Mothers Club, to empower this community to take up health as one of their major agendas. District task force, we often talk about like high maternal mortality. We often talk about the community, how they are contributing to the bad health indicators. But then if you look at the data, you don't find much data there. So district task force is chaired by deputy commissioner of each district, and there we are trying to only like understand the health related issues in tea garden, and also we are trying to define solutions from there. Multi-stakeholder forum, it is such an important aspect of the entire program, where we are bringing in all the stakeholders together. We have all the departments together, all the tea garden associations together, also the important community leaders together, and we are trying to drive solution from this multi-stakeholder forum. Strengthening HNC, like ZAS in HWCs, we are trying to strengthen these hospital management committees in the tea gardens, and from there we are trying to make whatever we are doing a sustainable. We are looking at a sustainability point from the HMCs, through the HMCs. Also, we are working very closely with the PSSNCs. So we understand this community platform, if we strengthen their capacities, then a lot can be achieved through these PSSNCs. So I will stop here, Radha, in the interest of time. If anyone has any question, I'll be happy to answer.
Thank you, sir, for sharing about your experience in about Saksam project and enlightening us. Anyone have any question? I think no. So once again, sir, thank you so much for your valuable time. Thank you.
Thank you. Bye.
May I now request Dr. Radha ma'am to continue the next session. Thank you.
Yes, thank you so much. So I think we have heard a lot about the work of Piramal Foundation through Anamay, the Tribal Health Collaborative, the Digital Bharat Collaborative, and now the work of Saksham, a project in the tea tribe of Assam. We now move on to another interesting session, So this one will be presented by our esteemed speaker, Dr. Jan. Dr. Jan Vandenberg has more than 25 years senior management experience in the international insurance industry. He holds a medical degree, MSc from Vrije University in Amsterdam, and an MBO degree from Rotterdam School of Management of the Erasmus University at Rotterdam and the Wharton School of the University of Pennsylvania. He's currently the chairman of Achmea, the largest healthcare insurance company in Europe. He worked for AXA and Prudential Finance as Asia CEO and lived in Singapore from 2007 to 2017. He is also advisor to the Ministry of Health of the Government of Singapore. He has a special interest in the development of healthcare systems across the world. So I have personally been working very closely with Dr. Jan in the last one and a half years or so. And we are working on something really interesting about which Jan will now speak in a session. So over to you, Dr. Jan, and all the best. Thank you.
Greetings all from Amsterdam. Hello, everybody. So, Radha, can you project my presentation?
Yes. I request the IT team to please project Dr. Jan's slides.
Thank you so much. Hello, everybody. I will speak about India reverse diabetes 2. And yes, we are talking about reversing diabetes. And I think, as all of you may know, that's one of the most exciting recent scientific insights, that diabetes 2 can indeed be reversed. I'll show you the definition of reversal later on, but let it be clear, it is about significantly reducing the HbA1c levels and or reduction of medication to the point that there are many people who are completely off medication. But it requires a significant change in lifestyle, and that's what this program is all about. Can we go to the next slide, please? Our program, as Radha said, can you move the slide up a little bit so we can see all the partners at the bottom of the slide? It's a partnership with 6 partners across the world. There are 2 partners in India. One, of course, Piramal, with whom we run this program in Assam, in a rural group of patients, and in Jaipur with the Eternal Heart Center with an urban group of patients. And we run this as effectively a proof of concept. So our program is based on a successful lifestyle program, which is run and developed in the Netherlands by the foundation Voeding Leeft. It's been running now for almost 5 years, and it has seen quite some spectacular results. 92% of all the participants have either been reversed wholly or partially after 12 months, which we are still very proud of, and still monitoring whether these patients adhere to the program after they've completed the program, and that's still the case. So this 92 is the cohort which has been running for about 5 years now. Can we go to the next slide?
May I, sorry, Jan, just coming in here. Utpal, may I request you to please zoom out a little bit to maybe 60% so we see the whole slide. Thank you.
Thank you, Radha. The main objectives of the program, of course, are about does this lifestyle program also work in the Indian environment, in the Indian culture, in the Indian cuisine? And do people really like it? Are they able to adhere to it? Do they like to adhere to it? That's objective number 1. Objective number 2, of course, is it effective in reversing type 2 diabetes? And the third and the fourth are really around cost levels and usable data sets, which we hope to establish. And the aim is that after this program has proved to be successful, that we will publish together with the Free University in Amsterdam and of course our Indian partners an authoritative scientific paper, after which we would like to scale up this lifestyle program across India in close collaboration with your government. Can we go to the next slide? It's a 3-month program in the Indian environment, and we work in group sessions with roughly 20 patients. The program is really around changing food intake and of course physical activity. We monitor the patients very closely. So if possible, we reduce medication based on the blood glucose levels. Professional guidance by nutritionists, coaches, and nurse practitioners. And in the urban population, we also use a lifestyle app. Can we go to the next slide? There we'll see the definition of reversal. Can you move the slide? Yeah. So that's about either reducing HbA1c to below 53 millimole per mole, or 10% if the HbA1c at the baseline, this commencement of the study, is higher than 58. That's one dimension. The other one is the reduction in medication class. And on the right-hand side of the slide, you see the classes of medication. So it's about reducing a bracket in this class, going from class 4, the most heavy, of course, insulin, to class 1, no medication use anymore. And partial reversal is either one of the two, and complete reversal is both. And in the Dutch environment, 50% of the patients was completely reversed, and 92 was the combination of both partial and complete. Can we go to the next slide? What are the key learnings in Assam? We are currently working on the data, so I can't give you the reversals yet, but actually we are seeing very, very good results. And in a couple of weeks' time, we can share the conclusions in terms of the analytical results. But we can see from the bi-weekly meetings that the participants really enjoy the program. I had the privilege myself of visiting in November with the Piramal team, and very visible that the patients really like and are motivated and are happy, feeling better, much more energetic. We can see in the biomedical data points that there are structural improvements in the blood glucose levels. So we're hopeful that we can show significant reversal percentage at the end of the line. Very interesting, and that is also the picture on the right-hand side of this slide, is the role of the peer educator. So in every patient group, there is one patient, and in this case, you see the woman on the right-hand side, who is sort of the playing captain. And she really takes care of the other patients, monitors them, helps them with the measurement of the blood glucose levels, which she is demonstrating here. And she makes sure that everybody stays aligned. And we feel that when the attendance at the biweekly group sessions is high, it is to a very large extent also connected to the active role of the peer educator. Very proud. And we thought a great invention, which Piramal was the author of. Another part which we find is very effective is that we include the family members. And of course, you can understand that when the eating habits need to be changed, it doesn't work if only one member of the family is changing diet. It is important that the whole family is changing diet. Can we go one slide back, please? It was moving. Yeah. And what we also saw very interesting, we did a small pilot group early 2022. So these people have already been 8 months out of the study. We are currently in the main body of the study, but the people that have completed the study in May last year, in November last year, they were still adhering to the program, which is of course very hopeful that this is not just a one-shot gun where people participate in the program for 3 months and adhere because of the fact that they have intensive coaching. But even after completing the study, they continued. And this is, we believe, and we ask these people ourselves, this is because they feel better, they feel more energetic, and they have been able to keep up. Another very interesting part is that we were worried that by changing the food intake to more, so reducing rice is one of the parts of the study, that the average cost would go up. and that could be a barrier, of course, for people to participate in this program. But all the participants have told us that in Assam, that was no problem. So they could accommodate the changed diet within their budgets, which of course is tremendous news. Can we go to the next slide? And that is about the urban part where there was really a rise in costing levels. And the other part, very interesting, is that in an urban population, it's very difficult to bring people together in group sessions. That worked much better in the rural environment, which may tell us that that could be actually a structural barrier to running these programs in an urban environment. So we believe that bodes very well for the program, especially in the rural environment. And hopefully after we've completed the study and have published the results, it will be deemed to be worthy for a pan-Indian rollout. I would like to conclude here, and if there's any question, I'd be very happy to answer them. If not, then I thank everybody for listening in, and I can only say it's a pleasure to work with Radha and the whole team in Assam. The visit was really heartening, and to see that people really improved their lives was very worthwhile, and taught us why we are undertaking this study.
Thank you so much, Jan. I think that was a very crisp and a very, very insightful presentation. At the same time, you mentioned 53 millimoles per mole, which in Indian setting is 7% HbA1c. So I would just like to clarify that for our audience. And I would also like to draw their attention to the fact that non-communicable diseases, because of their chronic nature, dependency on the health system, cause a great amount of out-of-pocket expenditure to the people living with NCDs. With a program that shows promise to reverse diabetes, may actually enable people to save on the catastrophic out-of-pocket expenditure that would have otherwise caused them adversaries in the family because of NCDs and their complications, dependency on the health system, frequent visits to doctor, multiple investigations, cost of drugs. I'm sure that this program will show promise, and we will be able to scale it up in the near future. Thank you so much, Jan. We have one hand raised from Dr. Rajendra Prasad. Yes, we could take one question, and for the remaining, I would request everybody to please keep the questions in chat. Yeah.
Right. Thank you. It was a crisp presentation, Dr. Jan Van. I am a public health man from South India. I have a couple of points to make. Number one, per se, the program of reversal of diabetes 2 is likely to raise high expectations in common people, which in my view is not a thing that should be encouraged. So the remedy would be to continue with the studies on a larger and larger scales, arrive at point, identify the feasibility factor with regard to the geography, food habits, racial features, and the pathophysiology of the origin of diabetes in different people, and then recommend it in a strong way. Second point I would like to make is, it appears 50% of the study people under your project have achieved total reversal and rest partial. I understand when you say total reversal, the need for diabetic medication has been brought down to 0. Am I right, Ms. Dr. Radha? That's one thing.
No, it's a reduction of one bracket. So it doesn't necessarily mean complete stop of medication, but it's reduction of one level in medication. So let's say from insulin to metformin, or from metformin to 0.
Achha. That would be in terms of percentage, 20% reduction in the medical expenditure, drug expenditure per month or so, roughly?
Yeah, roughly, I think you could say that, yeah.
That's one thing. Second thing is, it appears the crux or the essence of the approach or the principle depends upon the food habits and the food utilization of the people. Food consumption, as we all know, is conditioned by multiple factors. And in areas like Assam and in backward people, it is expected to be generally relatively more difficult to impose any new changes in their food habits. The reluctance in the population to adopt new ones and the economic compulsions and limitations play a crucial part. So what worked in European countries may not perhaps work equally to an equal extent in areas like Assam and other things. So anyway, it's a very good initiative. It has to be encouraged because the future belongs to diabetes. So every possible means and weapon to tackle it, to control it, should be heartily welcome. That's the thing. These are the two limitations points I had in my mind. Of course, I did not dig deep into this reversal process, but on my surface knowledge, these points struck my mind. I expressed them. Thank you.
Thank you, Dr. Rajendra. And you're completely right. I mean, the localization of something that works in the Netherlands to India is certainly not evident. And indeed, we have encountered many differences between the experience in India and the experience in the Netherlands, not only for food purposes, but also the cultural purposes, the way it's perceived in the families. It's very different. It was very interesting for us, but also very challenging. But at the same time, that's why we do the study, and that's why we want to understand what makes it different and how we can overcome these challenges. And as I said, it seems that in the rural environment, we've been more successful together in overcoming these challenges than we have been in the urban environment, which bodes well for the program in a rural environment, and perhaps does not bode so well for the urban environment for these kinds of lifestyle programs. But anyway, that's a preliminary results, and we haven't done the full analysis yet. But I'm very hopeful that at least on the rural side we can show some promising results. Thank you very much.
Yeah, thank you so much. Yeah, thank you, Jan, and thank you, Dr. Rajendra Prasad. I would also like to mention here that we have spent considerable amount of time trying to localize the program to an Indian context, taking into account the dietary practices locally, festivals, the whole family environment, cooking in the common kitchen, cooking using locally available low-cost food items. And all these practices are actually ingrained in the program that we are trying to implement. So your points are extremely valid and extremely valuable. And I want to assure you that we have had considerable amount of deliberation on these aspects of the program. So thank you so much for sharing your thoughts. I now hand it over to my colleague for the next session. Yes, Priyanki, over to you, ma'am.
Thank you, ma'am. Thank you, Jandenberg, sir, for your beautiful presentation. So now we can move to our next presenter, Toiba Sultana, ma'am. Am I audible to everyone?
Yes.
Okay. So a brief introduction about Toiba Sultana, ma'am. Toiba Sultana is a senior program manager of Aspirational District Collaborative of Northeast. ADC is a flagship initiative of Niti Aayog and Piramal Foundation, which aims to uplift 100 million people living in abject poverty in 112 aspirational districts. Toiba delivers program in education and youth by involving engagement of larger ecosystem, including the government machinery. She have 12 years of experience in the social sector and her passion lies in developing youth to become nation builders by imparting 21st century skills. So here, I would like to welcome you, ma'am, and I invite you to take over the session. Thank you. Over to you, ma'am.
Thank you so much, Priyanki, for that lovely introduction.
Thank you, ma'am.
At the very onset, I am extremely grateful to this forum for giving me this opportunity to talk about the potential of youth in aspirational district collaborative. And not only in aspirational district collaborative, from yesterday we have been talking about non-communicable diseases. There are so many problems, so many health challenges that every day we are facing, and how we can leverage the power of youth in actually solving some of the problems. So my presentation will be basically of two parts. In the first part, I will be talking about what is the Aspirational District Collaborative Program. And in the second half, I will be talking more about who are the youth power that we are mentioning about, who are the Gandhi Fellows. Yesterday, very briefly, Dr. Shailendra mentioned about Aspirational District Collaborative Program, and also he spoke about Gandhi Fellowship. Today, I will be taking you a little bit in detail. And the third portion will be covering more of what are the aspirational district collaborative Gandhi Fellows doing in the different aspirational districts. So all local fellows and how they are trying to solve and understand the problem of this region is something that I'd like to highlight. So I'll share my screen. Just let me know if it is feasible, okay? Is my screen visible?
No.
Not yet. Is it visible now?
No.
Your screen is not visible, ma'am.
All right. Am I the co-host, Priyanki?
Let me check, ma'am.
Yes.
Yes, ma'am.
I am?
Yes.
So I do the share screen. Okay. Just a second. Huh? I think I didn't check this option to share. Is it visible now?
Yes, ma'am.
Yes, ma'am. Yes, ma'am, it's visible.
All right. So before we move ahead with the presentation, I have to begin with a story saying how did the concept of aspirational district collaborative actually come into the picture. So the journey began in 2018 when our Honorable Prime Minister launched a program called Aspirational District Program. And these are these 112 most backward districts of India which needed a lot of attention, be it in education, be it in health, be it in livelihood, in every sectors. These were the districts which were left far, far, far behind. And therefore, in collaboration with Niti Aayog, this initiative was taken that there has to be a revolution, there has to be something that needs to be done to uplift the aspirational districts, which are actually the most backward districts of India. Having said that, how did the idea of collaboration come into the picture? Because it was very clear that there's 112 aspirational districts and they needed attention. So as you all know, in 2020, we were all hit struck very badly by COVID. And the pandemic was got into us a lot of learnings. All of us had to change our way of operation. How we were operating in the past was not the scenario now. We had to change in many, many ways. And this was during COVID. We had to work. So as all of you know, that Piramal Foundation works very closely in education, health, and water. And in all the three domains, there needed drastic change in our way of operation. So similarly, it happened with the aspirational districts. There are actually a lot of examples, but one example that I'd like to pick is this. So there was a lot of adversity. There was a lot of beliefs and concerns and challenges around COVID vaccine. people were very, very reluctant of taking the vaccine. And all of you is already aware of it, saying that it has severe after effects. There is, if I take one dose of the vaccine, I don't need to take another. There was inappropriate behavior, and there was a lot of misinformation that I'm still breastfeeding, taking the vaccine can be harmful for my child. So this was the situation in majority of the districts that we were working. And all of you know how important it was at that time for us to take the drive of vaccination across India. So in order to leverage the local community, the local people, we came up with the idea of why not involving PRI members, faith leaders, and the local community people to actually spread the news saying how the vaccine is not going to harm you, instead is going to benefit you the most. And to our surprise, there are more examples. Actually, I'm just displaying this now. There were NGOs, there were young volunteers who came forward, who went across mobilizing people in different ways, saying that how the vaccination is going to help them. And this is one of the major learning that we had during that time, that a collaborative of local community, whether it is PRI, faith leaders, SAGs, they are the ones who can actually take up local issues and local challenges and be the influential leaders and bring change in the community. And that is how the concept of aspirational district collaborative came into picture. Now, if you will see the aspirational district collaboratives, they have a particular characteristics, all the 112 aspirational districts, and they have their own set of challenges. So there are 20 districts which are actually bordering 5 countries across 12 states. So it has its own set of challenges because they are bordering to either international border or state border. 14 aspirational districts are in Northeast region. And as of all of you know, that Northeast region have their own challenges in itself, because each region is so distinctly different from the other region. Where Sikkim is so different from Arunachal is so different from Mizoram. And therefore, the complexities is much, much higher. 35 districts are such which are affected by left-wing extremism. There are 18 districts who are in hilly region, so therefore transportation becomes extremely difficult. There are 28 districts which are affected by flood, and there are 25 districts which are tribal dominated. So this is how you can visualize the hardships and challenges, both socio-cultural, geographical, and political challenges that these districts have to go through every day. And plus it is the remoteness. The remoteness is not only because of distance from the mainland India, but also because of natural barriers, sparse population, and it's got challenges to access. Now, if this were the challenges in the aspirational districts, we felt that this is high time that we need to form the aspirational district collaborative, because like I said in the earlier slides, it is only the local people who understand the local problem in a much, much, much better way. Me sitting in Delhi or someone sitting in Rajasthan trying to solve the problem of Assam, it's not going to be fruitful. Yes, we can learn a lot of things from each other. We can have the best practices, but the conditions of Assam will be very, very different from the rest of India. And therefore, a local community, a local faith. Sorry, is anyone saying something? Okay. So this local community taking ownership of solving local problems is something which was extremely, extremely important. And therefore, for the first time, we got this opportunity of coming up with this program called Aspirational District Collaborative. Now, when I say that in the collaborative, it is not only the hyperlocal channel partners that we will be joining hands with, it is also the government bodies that we'll have to join hands with. And why I'm saying that, because aspirational district collaborative is formed by the channels, which are our collaborators. And then we also have to do convergence. of various line departments within the government system. And why do we need to do that? For I can give you an example saying, suppose there is a child who is going to school. Is it only the education problem of the child that will solve all his problems or her problems? No, because this child might be also facing the problem of nutrition. This child is using the toilet every day and might be having drinking water and sanitation problem. So only education department cannot solve the problem of the child. It is all the departments have to come together. There needs to be convergence of all the departments, and only then the problems can be solved. So aspirational district collaborative very clearly focuses on two main buckets. One is your collaboration of the local partners and convergence of the various line departments. So this is what we understood as the challenge, because as we are working in health education and water during COVID response, that the district administration is trying to solve the problem, but there was no formal way to communicate the need of the community to the district administration. Similarly, district administration find it challenging to have the interaction between central and state government. So how do this entire thing, which is now working in aloof, which is now working, how do we get everyone together to solve their own local problems? So this we think is a sustainable model, because tomorrow, 15 years, 20 years down the line, even if we don't exist in the district themselves can take ownership and solve their local problems. Therefore, the focus of aspirational district collaborative is to build hyper-local solutions for community level problems by involving the community and understanding their needs. So like I said earlier, it talks about collaboration, convergence, and later on it will also help in creating policies which will be more grounded, because we will understand the ground in a much better level. Now, if this is the scenario of the aspirational district collaborative, if this is the goals that aspirational district collaborative wants to achieve, then what kind of people will be required to work in such challenging districts? Like I mentioned in the earlier slide, that every aspirational district have its own set of challenges. So we realized in order to work in such kind of districts, we need people who are dedicated, who are driven, and who are self-motivated. And to fit that lot, we have the best of our talent in the organization, and they are our Gandhi Fellows. So Gandhi Fellowship Program is a 2 years residential program where the Gandhi Fellows come and stay in the district for 2 years. And the main motto or theme of Gandhi Fellowship is Unfold, Impact, and Enjoy. So basically why we call it Unfold, Impact, and Enjoy is the fellowship focuses on two very, very important parts. One is that you first know yourself. First, you understand yourself. Who are you? You come here for personal transformation. It's not that I am a superhuman being and I am here and I will go and change the world. It's actually the other way around. In the process of working with the community, in the process of working for causes, for social problems, I know myself better and I turn out to be a better human being, or I work for my 21st century skills, by which after the 2 years of experience in the Gandhi Fellowship, I can do a greater contribution to the community, to the nation. And in doing this entire process, they do really enjoy it. So that's one of the core theme of Gandhi Fellowship. So a little bit about it. So it was born in 2008 with 11 Gandhi Fellows, and I'm one of the Gandhi Fellow. I'm a first batch Gandhi Fellow, and I feel very, very proud to say that. And taking Mahatma Gandhi's belief, be the change you wish to see in the world. Like I said, we believe in personal transformation. We are someone who is not saying that, oh, I am the one who will go and change the nation. No, I have to change myself first. I always have to have this inner I have to show the mirror to myself first before going and changing the world. Forward with self-motivated Indian youth, creating change leaders across. It's a 2-year full-time flagship program, creating youth leaders for nation building. And how we do that? They have exposure routines like leadership curriculums, boot camps, learning journeys, etc. Then they have some experiential learning like community immersion, system immersion, and they have some reflective practices because for their personal development, it's extremely important. Vipassana 10 days meditation that they go for. There is daily debrief and there is a reflective journey. So they learn by doing. They work in the community, they work with the government space, and at the same time, there is reflective and daily debrief practices by which they learn whatever they learned on ground. They come back and share it with their team and talk about it. So our milestones, how we have grown over a period of time. So in 2008, Gandhi Fellowship was launched with 11 fellows. In 2016, we launched the District Transformation Program in 29 states. And then we launched the State Transformation Program in 12 states in 2018 with over 550 Gandhi Fellows. To 2022, we had a mega expansion, and currently we have 1,200 Gandhi Fellows all over India. The number of Gandhi Fellows in Northeast currently is 60 plus, and across India, it is 1,200. So our development principles. So what is it that the fellows learn during the fellowship? So Gandhi Fellowship core values and principles are, what do they learn? They learn about leading self. Because tomorrow, if I have to lead the nation, tomorrow, if I have to be a millionaire where I'm touching or impacting million lives, first I have to know to lead myself. So leading self is something that I learn. Leading on ground impact. They have to make impact on ground. Why I'm preparing myself, why I am becoming this leader that I'm trying to become is because of the impact that I want to make on the ground. So therefore, how do I lead on impacting on ground? Third, definitely is leading people because they have to work with people. Leading with the organizational outcomes. There are different programs like Shailendra mentioned yesterday. We have THC, we have DBC, we have PU, we have ADC. There are different programs that this organizations run or the big bets that we have, and therefore there are certain organizational outcomes that we are expecting from the fellow to perform. Then it is leading social impact at scale. We as an organization have a deep belief in scale because India is a huge country and any problem in India is not small. It has to be solved at scale, otherwise it will remain or restricted to only few places and overall the problem will not get solved. So therefore, from the time they join the fellowship, there is training, there are workshops, there are boot camps where they are constantly they are taught or we make them understand that we have to think scale. So these are the Gandhi Fellowship core values and principles. Now, yes.
Please close in 2 minutes. Thank you.
Sorry, Radha, I didn't hear you. Sorry.
Yeah, could you close in 2 minutes?
I didn't hear you again.
Could you close in another 2 minutes?
Yes. I'll do that. Sure. Yeah. All right. So like I said, some of the pictures that I wanted to show you of different Northeast region. So fellows accept all hardships and challenges and they work in the community, which are, like I said, extremely difficult community. Hailakandi, this is one of the photo where there was a vaccination drive and they had to cross 3 rivers in a boat on the left side of my screen. And still they did it. The first person here is Dibakar. He's a Gandhi fellow in Hailakandi. The second picture is of Aradhana Saikya in Udalguri, and she's doing a self-help group discussion in Udalguri. This is in Dorong. This is the bridge that every day the fellows have to cross to go to a school in one of the communities. So they accept all these challenges and hardships and they continue still their journey. So fellows also learn about the community through a process called community immersion. It's a very, 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 very interesting process. I wanted to share more about it, but I don't have much of time. So this is 15 days, 20 days that the fellows go and stay in the community to understand the community much better, without any money, without laptop, without phone. So they live the life of the community so that there is a complete immersion process. And they also do the labor job that they family with they stay in, the labor job that their family does, they also do that. So this is a photo from West Sikkim, where this old lady is preparing a traditional Nepali food. Then there is one from Dhalai, where our fellow is helping out the laborers in the MG Narega. Then there is someone who's trying her hands in weaving in Kualpara. So this is community immersion. And after the immersion processes, after the induction that happens, they actually go out and work on field. And through aspirational district collaborative, whatever our objective of the program is, they take a first hand and they perform on ground. So there is in Ribhoy, Prema, who is addressing the district administration and sharing about that upcoming event or a campaign that is going to happen. And then we have Shankar from Namsai, who is addressing all the collaborative partners, SAGs, NGOs, volunteers. They come together and he's having a conversation with them. Then we have FLN activities in school, foundational literacy and numeracy, so that there is a demonstration in front of the schools, teachers and headmasters of the various activities. And in doing all this, these are the people, these are the Gandhi Fellows who actually understand the culture and the uniqueness of the district very, very well. There are actually a lot of stories, but I really have to stop my presentation now. So there is this culture in Mamit, Mizoram, where there is shop without shopkeepers. And this is a first-hand experience of a Gandhi Fellow. This is about Kuhili art, the art of Gauripur in Dhupri. And this is about the condition of schools in Chor areas of Barpeta. So this is all about the Gandhi Fellows. They are talented, they are dedicated, they are self-driven, and at the same time, they are committed to the community. And this is the potential of youth in overall Northeast. So I'd just like to end my presentation with one slide by Swami Vivekananda. He said, give me 100 energetic young men and women and I'll transform India. And this is one line that the people who started the Gandhi Fellowship Program have a deep, deep belief. And that is how we started the program. And this is how this far we have able to come because of this lovely young people that we have around us. Thank you so much. I hope I made sense. Thank you.
Thank you, Prabhasitana ma'am. It was really very nice to hear from you. So is there any questions? You can ask here directly to the ma'am, or you can write in the chat box. So well, we can move to our next presenter. So the next presenter is Sindhu Kulkarni ma'am. Hello ma'am, have you joined in the conference?
I'm here, Priyanki.
Yeah, okay ma'am. Okay, welcome ma'am. Welcome to the second Northeast Diabetes Conference.
Thank you, I'm so glad. Thank you very much.
Yeah. So I would like to introduce Sindhu ma'am. Sindhu Kulkarni, co-founder Tessit and Tessit Games, architect and product designer from IDC IIT Bombay, with over 15 years of experience in user experience, product visual communication design. She has worked with various startups, small business and NGOs. She worked towards infusing creative clarity in the building of product solution experience by combining roadmaps and research with design expertise. So it's my pleasure to working with you, Sindhu ma'am, and we are eager to hear from you about Tessit board game. So over to you, ma'am.
Hi, everyone. So glad to be here. And I've been listening into the presentations and all the amazing work, and especially Madam Toiba. We had an opportunity to speak to a few Gandhi fellows, and it was so inspiring because we are not from this area, and health has been very new to us. And yeah, we attempted to do a board game, and yeah, that's what I'm going to be talking about today. So I'll just share my screen. Thanks everyone for the opportunity, Dr. Radha, Shelly, and Piramal.
Yeah, so Sindhu, while you project the video and the slides, I would just like to give a little context to our audience and what this is about. So hello everyone, don't mean to barge in Sindhu's presentation, but just a little bit of context so that we are able to receive this better. So as one of our initiatives under the Strengthening NCD Services in Assam project, which is supported by World Diabetes Foundation, we form and train the members of what are called as Jan Arogya Samitis. So this is, I'm sure you all know about Jan Arogya Samitis already. This is a nationwide initiative of the Government of India. It is an initiative to drive community action for health. So while Jan Arogya Samitis are being formed in different parts of Assam, including the tribal districts, of course, and while our teams are engaged in forming and training the members of Jan Arogya Samitis, we also gave a thought to how this process of training the Jan Arogya Samitis can be made interactive, fun, and enjoyable for the participants, at the same time making it effective in a manner that the JAS members understand their responsibilities and they have an opportunity to practice what their roles and responsibilities would be in a game-like setup. So this is essentially gamification of Jan Arogya Samiti training. And I leave it on to Sindhu to talk more about how we did it. Thank you. Over to you, Sindhu.
Is everybody able to see my screen?
No, ma'am.
Yes, ma'am, it's coming. Yeah.
I think you need to go into slideshow. Yes, it's visible.
Yeah. So yes, from that introduction, here is the Samiti, a project that we've been working on for the past 7 months with Piramal Swasthya. This is how it looks. Let me go into the details of it. So first of all, why board game for something like JAS? So since Dr. Radha mentioned it was a community initiative, right? So we are actually trying to tell that people should take onus for the health of their own health and of their community, basically. And how do we do this, you know, in a community? And Jan Arogya Samiti being a very new initiative, a lot of people did not know much about it. And like the way she said, it was a way to get into an innovative way to train all of these people. So, board games are an arena which is being used extensively worldwide, you know, to impact outcomes in defense, education, health, and government and retail sectors and things like this. And in a complex ecosystem like India, why are we still not doing it? I mean, like, you know, we are using still very traditional methods of training, basically. And why is a board game effective? It's because everybody involves, and they are able to acquire multiple competencies by through one game activity, and it becomes a very fun, engaging learning process. And they reflect, so whatever they do, they have contributed in their individual capacity. So they reflect on whatever failures or success in the way they have played the game, and hopefully in their real life, they will actually apply these learnings And these kind of systems have been very effectively worked on in abroad, and being getting introduced, and many people are working towards this even in India. This is a public health challenge by a company called Perspectivity in Netherlands. takes about 2.5 hours of focused discussions with a lot of stakeholders, and this is how it goes. So we were trying to, so when they say a board game, we didn't want to do a very entertainment kind of a game. So there was an educational objective to it, and there was a defined objective. The defined objectives were that, these people, all the Jan Arogya Samiti committee members should develop a lot of their lower order and the higher order skills. When we say lower order and higher order, it's got nothing to do with cadre, but it's got to do with the cognitive the learnings that they will have to do. So it's, basically we are actually telling them to, actually train an active society demanding help from JAS. But how do we do all of this? There are so many things, there are so many aspects of the JAS that they need to learn, in terms of the activities, their roles and responsibilities, that, these are the things that they have to continue to do so that, we reach health in that place. And then they have to manage all the operational infrastructure and human resource and finance issues on their own, basically. So, they, it is something that it's an overall development for that entire community. And what do we focus our content on? We focused our content on all the JS guidelines, and we focused on working towards more on the not communicable diseases. And we decided, these were the constraints that we worked in, okay, we will restrict it to Assam, and we will restrict it to the kind of issues, culture, all of that, so that, because a board game is a very visual way of doing things, right? So when artwork comes in, we have to be very sensitive about the culture, and it had to be a scalable system. The kind of system was like, okay, if somebody wants to train entirely on NCDs, or somebody wants to just take up CDs, or somebody wants to take up only women and child health, the entire game has to be able to scale that way, and they should be able to break it and use it that way. And so we had a process. We did a lot of, we did 3 field studies. Product. There were many observations, which were for us, the context was new. We saw what the issues were, and then we had to come up with a game where, these were the kind of things we were looking at: process simulation, knowledge building, record keeping, scenario simulation, and majority opinion and role play, which actually work towards the lower order and the higher order skills that we want them to develop. We did a few pilot studies to actually see if it actually works as expected. And then we will actually show a video in which you can actually see what is really happening in the field, and how their involvement levels are increasing. And these are the these are the game features. Actually, it would need a lot more time to be getting into all of these into detail. But then we're working on these are the main game features. So this is how it looks, a semi-cooperative. These are the contents. It's very simple 4 steps that they do. And an introduction visually to all the people who are involved with JAS. How you work on your Pragati, how you work on the Samiti, what are the things, have you conducted public hearings? So these are the things that, answering all these questions will give them lifelines. They go solve missions. And these are the key activities. So it tells them about the activities of the Samiti. And then we have questions, which was something that everybody enjoyed, which is about knowledge building. And then we'll have an overall score tracker. So with this, I think I will request them to take on a video of the various pilots that we have done, which we've put together in a quick video. Hello?
Yes, I'm requesting the IT team to please play the video. Please make it full screen. Full screen.
আমার যদি বেশি হয়ে যায় মানে আমার ডায়রিয়া যদি বেশি হয়ে যায় ইয়ার যদি আমি মানে ঠিক কৰিব নোৱাৰো তেতিয়াই হলে তো আমি মানে ৰেফাৰ কৰিবই লাগিব
ঘৰত কিবা এটা হলে ঔষধ খুৱাই তাৰপিছত ঘৰত লৈ যাব মিনিমাম তো লাগিব গ্ৰুপ ডিসিশন আৰু ভোটিং
তার কথা মতে কি আছে তার কথা এই যুক্তি মতে এই
যুক্তি দিলে
বাজে সাবন
এবারে তো লাগে না
many instances and
pregnancy হয় এটো কৈ দিও এটো মিলাই দিও মানে মিলাই দিও কেনেকে মিলাই নিজে মতে কাৰণে প্ৰটিনৰ প্ৰয়োজন সেইকাৰণে এটো একলাৰ কৈ দিও
প্ৰেগনেন্সি হোৱাৰ লগে লগে আশাক খবৰ দিয়ে তেতিয়া আশাই মানে প্ৰেগনেন্সিত কি কি কেয়াৰ ল'ব লাগে কি বেজি ল'ব লাগে সব কেয়াৰবিলাক চাব অনুভৱ চাব বঢ়িয়া 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 এটো মেডকো ওয়েলনেস সেন্টার আই বলে এইয়া আশাই হাইপারটেনশনৰ কাৰণে এই কোম্পানী পাতিব লাগে পাব্লিক হেৰি পাতিব লাগে
এই যে কার্ড আছে কার্ডৰ মানে চেয়ারম্যান এজনে হয় ঠিক আছে চেয়ারম্যাन মানে যোন আপোনালোকৰ কমিউনিটিৰ চেয়ারম্যাन তেওঁ হ'ব চেয়ারম্যাन
फाइनल गोल होगा हमारे हेल्थ एंड वेलनेस सेंटर और जन आरोग्य समिति को कायाकल्प माइलस्टोन तक लेके जाना यानी हम कैसे साथ में बैठ के अच्छे के लिए सोचें
আৰু যদি নাই মোক খোৱা পানী লাগে যে বাইদেউ নাই মোক খোৱা পানী লাগে তেতিয়াহ'লে কমিটিটোৱে মানিব লাগিব যে নহয় এই সভাত আমি এই ডিসিশন ললো যে এবাৰ আমি খোৱা পানী একদম সিম্পল
उनके अलग से रखो दिखाओ मत
আমি ফৰি ফৰি হে ইয়াৰ এনসারটো ইয়াৰ ৰিলেশন
আপনি এক নাম্বার দুই নাম্বার দিব তো চাৰিখন কাৰ্ডত এইটো এক নাম্বার এইটো দুই নাম্বার আপনি এক নাম্বার কোনটো দি
ফজা বতা সৃষ্টি কৰ পাৰে কেৱল
আপনারা রাখো
লাস্ট কার্ডৰ ডিফারেন্স
আপোনালোকৰ কাৰ্ডত কোনটো কারেক্ট আনসার হ'ব
लेवल पेयरिंग ऑल योर थॉट्स या 4 और उसमें 1
হ্যাঁ চাৰিটা বেস আগৰ নিচিনাকে চাৰিটা বেস বাছক তাৰপিছত আকৌ তাৰ পৰা এক নম্বৰটো আপোনালোকে দিব
अगर हम ये देख रहे हैं तो सब बोल रहे हैं स्क्रीनिंग करना है दूसरे भी स्क्रीनिंग करना है ये बोल रहे हैं कि हम सब मीटिंग करेंगे इसके लिए प्लान क्या करना है फंड्स टू इम्प्रूव अवेयरनेस और मेंटेन और ऐड फैसिलिटीज 3 लोगों ने बोला कि सर्वे करना है तो इधर आपको कंसेंसस नहीं मिला
जो बीमारी फैल रहा कर रहा है तो इसको कंट्रोल में लाने के लिए जल्द से जल्द हम बीमारी को मुक्त कर सकें
फ्राउ इसे गुफुरहां जागोन है बे नर्माल बिगुरनिफ्राय इसे व्हाइट जागोन बिजि लगन हानिले दासला
खाओ पान सुपारी तांबूल खैनी सैनी खाओ খোৱাৰ কাৰণে আমাৰ ভিলেজত বিশেষকৈ কাৰণত পান সুপাৰি তামোল চামোল খাওঁ হয় নাই যাৰ কাৰণে আমাৰ দাঁতৰ বেমাৰ চেমাৰ হয় বা মুখৰ যিটো বেমাৰ হয় আৰু তাৰ কাৰণে কোনো সাৰ্ভিস নাই আপোনালোকৰ গাঁওখনত সো ইয়াৰ কাৰণে কি বেষ্ট সলিউশনস আপোনালোকে কৰিব পাৰিব মানে अभी ये जो चारों आंसर आया है हाँ ये सभी लगभग सही है हाँ बोल के हाँ वोट दिलवाता है तो नहीं करेगा देखते हैं সোনকালে ক'লে আমি সোনকালে শেষ কৰিব পাৰিম
trying to map the entire JS process and the happening thank you everyone for your time. And we hope to actually, we would love to see the impact, or we would love to keep on improving on the game as we go. Hopefully able to scale it.
You, Sindhu ma'am. So if you have any questions and feedback regarding this tacit board game, so you can ask here, or you can write in the chat box. Hello, somebody is speaking.
There is a hand raised from Kirtana. Kirtana, yeah, one quick question, then we move on to next.
No, Radha, that was by mistake.
Okay.
Oh, I was quite happy to.
Yeah, okay.
Thanks.
So thank you, ma'am. Thank you, Sindhu ma'am, for your beautiful presentation. So now I would like to hand over this platform to Dr. Radha ma'am.
Yes, hello. Am I visible? Am I audible? So
Yes,
next,
ma'am.
yeah,
Yes,
next
ma'am, you
we
are audible.
have Dr. Gunjan Nath, who is the Cardiovascular Health Officer under India Hypertension Control Initiative. I request Dr. Gunjan to share with us his experiences from the India Hypertension Control Initiative in Assam and Northeast, and share the learnings and the way forward from this program. Thank you.
Thank you, Dr. Radha. I hope I am audible.
Yeah,
Hello?
you are. Please continue, and you would have about 5 to 7 minutes. Thank you.
Yeah, sure, no issues. Can I share my screen? Okay, thank you. I hope my screen is visible.
Yes, sir. Yes, visible, sir.
So a very good afternoon to all the participants here. As I have been listening to the last few sessions, I really feel privileged to be a part among all these allies. And for this, I'd really like to thank the organizers for inviting me and giving this presentation. I'll make it as brief as possible. I will be talking about mostly about the India Hypertension Control Initiative. India Hypertension Control Initiative was basically launched in November 2017 in 5 states in India. It was basically partnered with Ministry of Health and Family Welfare, WHO India, ICMR, and the various state governments. It was based on the WHO Hearts package, and it was done idea to strengthen the hypertension treatment component of the national program. As we all know, the National NCD Control Program, NPCDCS, is concerned with 5 major diseases: hypertension, diabetes, and the 3 common cancers. IHCI was initiated with to strengthening this component of hypertension. So IHCI is based on the WHO Global Hearts Package. It has these 6 components: lifestyle, evidence-based protocols, access to essential medicines, risk-based management, team care, task sharing, and systems of monitoring. On the basis of this, the IHCI has 5 crucial components: treatment protocol, medication supply, team sharing, information system, and patient-centered care. I'll just give a brief on all this. Treatment protocol basically means For management, a simple and detailed protocol is established. As we all know, guidelines are already available, but a protocol is more specific. It specifies specific medicine as well as the doses and eases the load on the primary care physician and enables his confidence to prescribe medicine without any hesitancy. But only protocol will not suffice. Essential uninterrupted medication supply is the next part of the IHCI intervention. For this, we work with the governments, and NHM to strengthen the drug supply system. Also, we based about team-based care and task sharing. What is this? Basically, it facilitates all the health workers who are accessible to patients to provide and follow up in conjunction with the physician's orders. Basically, it implies that every member of the healthcare team should be sufficiently and optimally involved in supporting patient care. For patient-centric care, what we is basically the patient should be, the care should be more in line with the patient's conditions. Patient should not be required to move a long distance to get this treatment. Basically, increasing patient's convenience of medical visits, maybe for those already under control, medicine can be given for a prolonged period. If possible, all the free essential supply of all the medicines, preferably. Use of once daily treatment medicines. Basically, these are all patient-centric care systems, mechanisms, and the information system. Whatever management we do, whatever follow-up we do, without backup information, we can't learn from what is going on. So for this learning and information system is really important, that allows real-time feedback on all the programmatic performance indicators so that we can update ourselves and improve the program per se. It also will help us to give an annual estimate of the coverage, and the resulting standardization will improve the ability to evaluate the program impact and adjust as indicated. Now, with all these in place, IHCI was launched in 2017. It is currently being implemented in 141 districts across 25 states and more than 22,000 health institutions, including almost 16,000 health and wellness centers. We have around 37 lakh hypertensive patients enrolled with an control rate of nearly 44 to 45%. In the Northeast, except Arunachal Pradesh, Tripura, and Meghalaya, it is also being implemented in all other states. As we can see in this slide, Northeast, Sikkim was the first state in the Northeast to start IHCI back in 2021 January, followed by Nagaland. Manipur and Mizoram started last year. IHCI has been launched in Assam from January of this month in 2023. It is so basically IHCI is still in infancy in the Northeast states. But still, we can say that IHCI supporting INPC research has been able to enroll patients of nearly 1 to 10% of the estimated hypertension, when we have been able to achieve control rate of nearly 25 to 30%. Of states who are not yet implementing, Arunachal Pradesh and Tripura will be launching shortly. They are in the finalizing the project details, and Meghalaya has already doing similar activity in their own capacity. So I'm glad and actually privileged to inform that IHCI had received the UN Interagency Task Force Award in the last year at a UN General Assembly side event, 21 on 22nd. So learnings. Basically, my topic was learnings in Northeast. So I have just 2 slides, just simple. We had discussed what were learnings are. I have classified the learnings into 5 points, and I'll talk about each point individually. So what we have learned from the implementation of IHCI is that unless we identify more hypertensives, we will not be able to control. We will not be able to bring them under our purview and treat them, and thereby control the hypertensives. So how do we identify the hypertensives? For this, we had observed that when we do a linkage between population-based and opportunity screening, it brings the best of both, and we are able to bring a large number of hypertensives under our purview. Similarly, NCT corners or clinics in the hospitals, wherever possible, especially in the CHA and above, has enabled us to identify more hypertensives by increasing the opportunistic screenings. Then how do we limit barriers of patient access? We do that by ensuring inclusion of all protocol drugs. First, in IHCI, when we talk about the protocol, we mandate that all the drugs that are in the protocol need to be in the ADL of the state, so that eases upon the state to procure those drugs. Since only a limited number of drugs, three or four drugs will be there, so it will also ease the load of the state to procure drugs, thereby decreasing the expenditure as well as uh, easing monitoring of the drug availability. Also, regular medication supply. We have observed that patients do come to the full hospitals. If they are confident, then the hospital will have the medicine they will be prescribed. So we have observed and actually verified that regular medication supply and availability at the health facilities improves patients follow-up. And unless we improve the patient's follow-up, we will never be able to control the blood pressures of the patients. Then comes about ease of access. How do we ease of access? In states, we have observed that decentralization of hypertensive treatment. That is, once the patient is diagnosed by a medical officer, if the follow-up part can be done at the HWC level by the CHO itself, that is the nearest to the patient's home, it will increase the treatment compliance. Monthly or regular visit to the PHC, which may be far away from the patient's facility, may not be feasible for everyone. But a health and wellness center is more easier to access. This has resulted in the improving the follow-up patient as well as take-up of the IHCI. Furthermore, using the ASHAs to improve follow-up of patients, that is community mobilization, has also seen to be quite convenient. In fact, in most states, ASHAs are being given an incentive of some amount. In Assam, it is about 50 rupees per patient for every 6 months follow-up. In this way, they can be also motivated to bring those patients under those already identified hypertensives under the learning system, under our IHCI or MPCDCS. In the next part, how to improve the quality. Capacity building of the staff can be done for effective management. IHCI implements a very short and brief module of training module. This can be given it can be discussed even on a face-to-face discussion. And so it will ease up the team. Increasing the capacity of the staff will improve the effective management and also boost the confidence of the patients, physicians to treat better. Decreased therapeutic inertia by regular supervision and hands-on guidance has also proven to be quite effective. We have observed that in most cases, even after the patient is coming to the facility regularly, the BP blood pressure is not under control. This mostly because the physician or doctors are sometimes not ready to increase the dose. This is what is called therapeutic inertia, and this can only be decreased by regular supervision and hands-on guidance. Thereby, and further, the strengthening continuum of care is the same thing. Once the patient is diagnosed, he need not come to the same PHC again and again. He can be referred back to the CHO, is the nearest HWC, and follow-up can be done there unless any change in there. Also, with the presence of e-Sanjeevani teleconsultation has enabled patients to take up consultation from the ease of the HWC level itself. Then, what about enabling policies? Effective planning through the PIP for training, drugs procurement, diagnosis, and human resources we have found to be quite important. Unless we have funds to procure a limited amount of drugs, it becomes difficult to make the drug available. High quality digital blood pressure monitors, professional blood monitors are expensive, and for them to be bought, state will need to incur expenditure. And for those planning in the PIP, effective planning in the PIP is required. And furthermore, drug supply chain strengthening is quite an important task because we have observed that even when the drugs are available in the states, in the districts, there are numerous facilities where drug may not be found because the facilities don't receive drugs. The dispersed distribution of drugs may not be uniform. Some facility has more usage while others have less usage. This has resulted in non-availability of stock out of the same drug in some facilities, whereas in some other facilities, drugs may be in excess. So this is what is the drug supply chain strengthening. So under this, IHCI also tries to train the pharmacist to improve the drug supply availability, and thereby district and the state as well as eventually lead to the effective and uninterrupted availability of drugs. These are basically simple findings that we have observed, but this has produced effective results. Whatever we have seen. I will still mention that IHCI in the north is quite new and we have a long way to go. In whatever time we have observed, the states are pretty compelling and very excited to take it up. In fact, we have received, so we have Sikkim, West Bengal, then Nagaland are trying to take up more districts under their own strength without the support from partners, thereby taking up the overall IHCI. Eventually, IHCI is being taken up as a project under the NPCDCS program, and the cohort monitoring system will be taken up by the NPCDCS. This is all I'm going to say. Thank you so much. Thank you, Dr. Radha.
Thank you so much, Dr. Gunjan. I think this was very insightful. Do we have any questions? Do we have questions on the India Hypertension Initiative, Control Initiative, sorry. So there is one question in chat. It says more than half of hypertension patients are under the medication care of private doctors. Does this program have any plans or mechanisms to intrude into that sector?
Thank you, sir. It's a very valid question. As of now, public sector, private patients, we are not taking up any private patients, but we are in the process of looking into how do we bring those patients under our purview. Wherever they take the medicines, up to them, but following up them up and whether those patients are have the BP under control should be checked regularly. And we are trying to develop into systems of monitoring to develop that. So as of now, we don't have that. I'd say doesn't involve that, but we are in the process of developing something. Thank you for the question.
Okay, thank you. So I think we will close the session. Thank you so much, Dr. Gunjan, for making it here today.
Thank you.
Yes, so we will now have lunch break for exactly 30 minutes. So we come here at 2:10 for the next session. So we are actually running behind schedule and I apologize for that. But we hope to cover up in the second half with all the sessions that are planned. So see you all in 30 minutes from now. Thank you.
Thank you.
Thank you.
আহেনি
व्यस्त है कृपया प्रति
Hello.
Hello, Professor Polly. Yeah, we are just waiting for the team to join in. Yeah, in a minute.
You can hear me?
Yeah, perfectly all right. You're
Okay.
visible as well as we can hear
I'll
you.
just. Okay. Thank you.
Is everybody back?
Yes, Dr. Radha. Professor Polly also has joined.
Okay, so I welcome everybody in the post-lunch session, and I hand it over to you, Matu, to introduce Professor Polly.
Okay. Okay, welcome everyone to the second Northeast Diabetes and Lifestyle Conference. And it's my pleasure and honor to introduce Professor Polly Wacklin. She is a professor at Guwahati University of Women's Studies. Let me read out the formal introduction and then I'll invite her to speak. Professor Polly Walklin is the professor and HOD in Department of Women's Studies, Guwahati University. Her area of specialization is gender, geography, women's studies, gender and climate change, ecofeminism, and gender-based violence. She was awarded her PhD from NEHU, Shillong, for her thesis on gender-related crimes in Greater Guwahati urban area in 2006. There are more than 20 scholars who worked under her on various issues relating to women. She has published various papers in international and national publications, as well as presented papers in national and international seminars, namely USA, Singapore, Spain, Sweden, and Bhutan. She is affiliated to various academic and professional associations. She is engaged in organizations and institutions like the US Consulate Kolkata, Uppsala University, Sweden, UGC, New Delhi, National Commission for Women, Assam State Commission for Women, Northeast Network, IOC, UN Women, OKDISCD, and banglanatak.com, etc. for research and academic works. She completes research projects. She has completed research projects on surrogacy, sexual harassment of women at workplace, socio-cultural, political and economic status of women on Northeast, and water conservation, menstrual hygiene management amongst female students of Assam. At present, she is engaged with the collaborative international research project as a research consultant with the UN, Unilever, and MacLeod Russell on prevention of violence against women and girls program in Assam in the tea estates of Assam. She was engaged as a member for the Assam Care Program of Government of Assam during COVID-19 pandemic. She was awarded the Gender, Place and Culture Award 2009 for a new Emerging Scholars by Gender, Place and Culture, a journal of feminist geography by Routledge, Taylor and Francis Drew. She was part of Think 20 of G20, which was held recently in Bhopal on 16th and 17th January 2023. We welcome you, ma'am. At the same time, I want to set the context of inviting her today. We are trying to broaden the horizon of when we were speaking of traditionally, I would say, cultural aspects like health, diabetes, and lifestyle. But when we look at the broader context, at least in the Northeast, we see that there are an array of socioeconomic and socio-geographic, socio-political, socio-cultural aspects, which the umbrella of just healthcare cannot cover. So we want to broaden our horizon and know more about it from the gender lens. So we have Professor Polly with us today. Thank you so much for making time, and sorry for a bit of delay.
No problem. Thank you so much for inviting me as one of the speakers for today's program. And a very honest confession, I am actually not an expert from medical background, but in due course of me teaching or being a part of Women's Studies Department, there are various observations which has come to my notice, both by going through different research work or being a part of research activities, and also through different observations. So today, I would like to highlight a few things regarding women and health and how lifestyle plays in when we talk about women and health. And before I come to the health issues, there are certain things which we are all aware, but I would again bring to your notice is that when we talk about women in the context of a position, socio-economic and cultural position in a society, we have to accept the fact that she doesn't hold a very strong position, even though the society tries to portray it in that way. But if you look from a very in an in-depth way, we find that women always had a subordinate position. Women do not hold a strong position in every section of the society, be it social position, cultural position, economic position, political position. It is because of various practices that happens in the society. It is because of, mainly we can say that it is because of the patriarchal system, which is legitimized by the society, which puts women the way she is now. And this is not my saying. If we go through the different data about women in India, it's not so very pleasing one. Now, if we go, if we go according to the data of, because now we are into Sustainable Development Goals. So if we look at Goal 5, which talks about gender equality, of all the goals, Goal 5 is the worst performing goals of all the goals of sustainable development. And Assam happens to be one of the worst performer in Goal 5, which is in regard to gender equality. And again, when we look at the gender gap index, which has been formulated, and every year the report comes from World Economic Forum, we see that the gender gap, and in that gender gap index, it talks about the gap between men and women. And forget about the third gender. We hardly have any information and data about the third gender. So if we look at the gaps of men and women in the context of gender gap index, then India's performance is dripping every year. So which indicates the gap between men and women is increasing. So that is the backdrop. And from there, if we move ahead, then if we look at the lifestyle and how it is impacting our health, these are a few of my observations. Maybe because of a lack of voice, if we look at the work front, in the professional front, because of a submissive position at home, that gets also reflected in the workplace. So she may not, I'm not saying that all women are like that, but a majority of them, they may not have a voice. They may not have a voice to resist. They may not have that self-confidence because of the way they are socialized, or they may not have, or they may not take the forefront when they want to raise their voice. It is because the way of the gender socialization, that they need to take a backseat, they need to be submissive, they need to be felicitator, but take the prime part, or take a strong stand. That masculinity is not being inculcated. They need to be feminine, for which at times they may be overloaded with work in the workplaces. They may not, they may be overloaded, and they may also face different type of sexual harassment. And this may have an impact on their health, which may have impact on their mental health, on the physical health, and the mental well-being also. So this is one part which I wanted to highlight. Like, because of a position, it may have an impact on our work, and that might have an impact on our health. And it might be physical, or it might also be mental health and mental well-being, which is still not been addressed in policy level. So mental health should be looked into from gender lens and should be part of policy in workplace. Now, when I come down to the cultural side, or the how tradition induced or cultural induced lifestyle, one thing which I have noticed, and is the from religious point of view, like women tend to keep fastings. So and those fastings mostly, and those fasting, even though it is something which is related to Hinduism, but I have seen that since I'm from a Christian community, Christian religion, I've seen that fasting has also come into Christian religion in Assam. So, and this fasting is very intensive among the Hindu communities, or among the Hindu religion practitioners, and more so women. So these fastings has tremendous amount of hazards for them. And sometimes, and also another rituals, and like how it can have, because sometimes I've observed women, I haven't done any study, it is just my observation, like some women keep fastings for 3 days in a week. That means they're properly fed for 4 days in a week. So, and definitely it's going to have an immense impact on the health. And again, there's another rituals, like among the Hindus, is that which is which again differs according to different communities. If it's a Bengali speaking community, it's a Assamese community, or tribal community, it will be again different. But it is usually seen that women first, after performing the puja, they break the fast and they go for the breakfast, mostly for women who are into household works. Hello, can you hear me? It got disconnected, sorry. Can you hear me?
We lost you for a minute or so. Yeah, ma'am. Now we can hear you.
Yeah. So because of these rituals, and yes, I was coming to that point, like how women intend to, they break their fast after going for the, after the morning worships and all. So it is seen that most of the, like it's a long fast after the dinner. It's a long fast which they need to keep. For example, dinner, most Indians, they do not go for early dinner, which is very common among the hilly areas, or people living in the hilly areas. Like they go for early dinner, maybe at 6 p.m. or 7 p.m. But usually in the other communities, we see that dinner is pretty at around 9 or 10. So from 10, sometimes the women, after finishing their household chores, then they take the bath, then have the first meal in the morning. So, which is a gap of sometimes maybe 12 hours, even 14 hours, which definitely has a huge impact on the health. And this is a culturally induced health hazard, which we see mostly among women. Another thing which I would like to tell is about, which I myself feel it and which is my observation, is our dresses. The dress is also culture driven. So like if we look into the dresses of women, we find that only maybe 5% of the body is exposed, like only the face and the hands. And when the and if the body is covered, if 90% of the body is covered, that means 10% of the body is exposed to sunlight. And there is, if it happens for a prolonged period, then it leads to the deficiency of vitamin D, and thereby which affects the calcium intake and formation of the bone. And this, in the long run, I feel that dress habit is one of the factor for which women, after attaining the menopause or also prior to that, are facing different orthopedic issues like osteoporosis, osteoarthritis. So these are some of my observation. And another which I would like to talk about, the food habits, which is so very gendered in nature. Now, if we look, maybe you can do a quick exercise, mental exercise immediately. Like when food is served in a family, who gets the best share? Who gets the biggest piece? Who gets the best piece? It's not the women. So if you look at the women's plate, or if you look at your wife's plate or your mother's plate, then you'll find that she'll be the last one to take. She'll first distribute it among everybody, because that is how she's socialized, and because she's the provider of food, she's the nurturer of the family. This also impacts her food habit, the way she takes intake habit of food. Like she'll take the worst, and whatever is left, she takes it. So all this has an impact on her nutrition and thereby on her health. And with that, I would like to finish. Thank you so much.
Thank you, ma'am. I mean, at times, that's probably the reason I bought you for your insight, and you did cover it very succinctly. That the factor that, I mean, it's so obvious in our eyes that it is not a, I mean, even if our modern families in urban cities, even if it's not a hierarchical anymore, at least in that sense, but at least that it is swept into our culture in a way, like seeped into our whole soft thing, that the women ends up eating, and that itself might in the long run, and especially of course in rural areas, in your work you have seen the fasting part and everything. I think that definitely affects when we speak of balanced diet, or a diet which will control non-communicable disease in the future. So thank you for bringing in the perspective, and thank you for being with us here today. In future we look forward to collaborate in some form now. Thank you. I now also, because in lag of time, I invite Milind, who is here. Milind Dotto, as some of you might know, is, of course, he was a software professional in US and everything, but he is also a champion of queer rights here in Guwahati. And he has done some prolific work. He is also, he's produced a national award-winning film, and probably the first trans person award, national award, has gone to his film, Jonaki Porua. And we just wanted to make this conference very inclusive. So he will speak for a couple of minutes on his journey, and how, as a society, when we look at, I mean, everything, we kind of somewhere we might misplace the trans person and the queer person. So Milind, I invite you today for a couple of minutes of talking on this topic.
Thank you. Can you hear me? Can you hear me? Hello?
Yes, yes.
Yeah, Milind, we can hear you. Yeah, yeah.
Okay.
I know your network might be bad somewhere in Jorhat, remote Jorhat, but yeah, we can hear you.
You're
all right.
audible.
Okay, I just turn off my video because I'm Dhemaji. Though I wanted to make everybody jealous for a few minutes because I'm in a very beautiful area, and behind me is Arunachal Pradesh, and I am in Vidyadi Living School. I don't know whether you heard about Vidyadi Living School. They're doing excellent work in interior Dhemaji, just next to Arunachal. And so I'm here, and I just came to know about this meeting. So as Madhu had introduced, so first of all, thank you, Madhu and Parimal Foundation, for inviting me. So I am a proud Assamese trans person, and I am working on various things along with LGBT issues. And so quickly, few things I wanted to say that as a trans man, for me, it's very difficult to get healthcare services. I have to really think twice before going to any doctor, specifically in India and Assam, because quite often they do not know how to deal with a trans person. And I don't want to be a laughing stock, or mainly the doctors, or the people who are working under doctor. They are not used to a trans person coming toward them, or for treatment. And specifically intersex. For intersex are the person who are born with both genitalia. So there's hardly any studies done for transgender, LGBTQ people, and intersex, not even in the medical field. So around 4 years ago, we requested, in fact, I had to stay back 3 days in Dibrugarh because we wanted to have a queer talk, and principal did not allow us. We had to really fight for it. Finally, we had an unofficial talk about queer awareness program in Dibrugarh Medical College, which is one of the oldest medical college. And same thing happened in Guwahati Medical College. We had to fight for a queer awareness program. And I got help from Dr. Maithili Hazarika and others. And after like 3 or 4 days of persistent requests, we managed to have a queer program, queer awareness program. And for trans men, basically 3 things are very important. That is mental health and hormone endocrine I cannot spell it properly, but hormone treatment and surgical. So 4 years ago, there's only few cases, but now Guwahati Medical has quite a few cases. They are doing excellent work on mental health part. And for hormone, they have recently started taking cases. So which is a progress. They have around, I think, 4 or 5 people coming to them. But for surgery, nothing has been done yet. So most people have to go out of Assam, or they have to go to Calcutta and Delhi and stuff like that. So I hope, I really thank Madhu to including us. Yes, people has to be, it's a, what do you call? It's a very big step that people started talking about transgender. I also would like to correct this. Basically, trans people do not like to call as the third gender anymore, because nobody said that man is first gender or women is second gender and the transgender are third gender. That will become so that become controversial. So I wanted to point it out, and quite a lot of, because uh, quite often transgender people are not accepted at home, and they are not accepted in school, and also don't get good job. So quite often, that's why you see the Hijra community, right? In outside India, you do not see a Hijra community. You will see trans women, but you do not see Hijra, because we are not. I'm able to talk to you because I was accepted. My family accepted me. I had a good education and had a good job. So that those are the main basic thing that we lack of. The trans people do not receive. So this is my humble request to everyone, that if you know about any trans person, if they're struggling, so you can reach out to us. There's quite a few organizations also now in Guwahati, or in Assam. There's Homonoi, there's Habdo in Teshpur, there is Jersey in Dibrugarh and Jorhat area. So reach out to us. And recently there's an incident happened that one girl in a prominent school in Guwahati, she was being harassed. She's a trans girl. She was in 9th grade, and she was harassed, and she requested us. Then we went to school. Then we really had to pressure them to have this conversation, because she was bullied in the school. This other student had asked her to show her private part, prove that she's a girl, and a lot of other stuff. And if that happened to a girl, then people would have say, and took it very seriously, and would have said that this is a molestation case. But because it happened to be a trans woman, even the school authority did not wanted to have the discussion till April. And we have to really pressure them to have this discussion, because every life is important, and there's a very high rate of suicide and mental health issue with the trans community because of all this, because of they are not accepted, because they cannot they don't get the love from parents or from a teacher or classmates or friends. So that's what I want to bring it up. uh, I will
Thank
not
you.
take much time. You can reach out to me if you have any question. My name is Milind Datta, and Madhu has my number. Thank you so much, Madhu.
Thank you, Milind. Thank you. No, this means a lot, because these are serious conversations, and I wanted to bring to around 100 participant audience, and later on YouTube also, this is live through this conference, that we at times forget about the very little minor kind of populations and subpopulations and people who are out there. And by bringing you, and you have already created a strong voice in Assam, and the bigger part is you created a film on Jonaki Porua, which is Firefly in English, and won an award. And so you're trying your best, and many other partners with many other partners. So I request, whenever we are planning something, not to forget the trans community, the queer community. And as Milind pointed out, across Assam, there are many small pockets of queer communities. If you look around, you can reach out to them as well and include them in your programs. And so thank you for having this. I mean, some people might perceive this as uncomfortable, but that is also a part of public health, where we bring in uncomfortable conversations, because things are happening around here, and that is the truth. So thank you, Milind, for all your efforts towards the trans and queer community. And I now hand over the session to Latashri at the Secretariat Conference Secretariat. Thank you, Milan. And thank you, Professor Polly, for being with us here today and making time. Yeah.
Thank you, Madhu sir, and thank you so, Milind sir, for your valuable speech. It's really helped us. Thank you so much. Now I request Dr. Radha ma'am to take over the platform. At first, I will introduce Dr. Radha ma'am with you all. Dr. Radha, as a medical doctor with specialization MD in community medicine, she heads the World Diabetes Foundation WDF funded project strengthening NCD services in Assam, implemented by Government of Assam in partnership with Piramal Swastha. She started her career as a state epidemiologist for NCDs, Director of Health Services for Goa, India. Then went to lead the first of its kind state level technical support unit TSU for NCDs in Maharashtra, implemented by Piramal Swastha in partnership with Government of Maharashtra. Dr. Radha, MD in community medicine, is backed by a university rank in RGUHS, Karnataka, and a total of 7 awards for research paper posters. She has authored the chapter Environment and Health in IAPSM Community Medicine textbook. She also holds 2 fellowships. One is adolescent health and other in health policy and system research, which is ongoing. So now I request to hand over the platform to Radha ma'am. Over to you, ma'am.
Thank you so much, Lataji. Thank you for the kind introduction. Good afternoon once again to everybody. I would like to share my screen. Yes, can somebody confirm if it is visible in slideshow mode?
Yes, ma'am, it is visible.
Visible, ma'am.
Yeah.
Is it in slideshow mode?
Yes, ma'am.
Okay, thank you so much. And am I clearly audible?
Yes, ma'am, you are audible.
Okay, thank you. So I think in the last 1.5 days, we have heard about a number of initiatives taken up by a number of people, questions raised by different people, important discussions, important considerations. And I am here now to talk about another important topic, which is physical activity and exercise. And I would like to start the session by sharing with you our experience from the project in Assam, which is called Strengthening NCD Services in Assam. This is about how we got the community moving. So why focus on physical activity? There's a saying that obesity runs in the family when nobody runs in the family. So I'm sure we all know that physical inactivity, which means just not exercising enough and having a sedentary life for a major part of the day, is the risk factor for overweight and obesity, which in turn is a risk factor for every other NCD, be it diabetes, hypertension, cardiovascular diseases, and some cancers too. So gone are the days when obesity was a disease of the rich and of the urban areas. Today we see an increasing trend of overweight and obesity in men as well as women, in young as well as the old, and in rural as well as the urban areas. There is an increasing predisposition to sedentary lifestyle, both in urban as well as rural areas. Not all young people from rural and tribal areas are into agriculture or physically laborious tasks. Things are getting mechanized, and so is our lifestyle. I think most of the people who are here in this forum also have a sedentary lifestyle. You just like get up in the morning, you sit on the pot, you get ready, you sit in a vehicle, go to your workplace, you sit there the whole day, you come back home, you're tired, so you sit to rest again, and then you go to sleep. This is the kind of life which most people around us are leading. And needless to say, rapid urbanization in the last few decades has given us so or unpackaged. Packaged is everything that comes with a label. And unpackaged is processed food which is sold loose. So it may be sold street side, or it is available, say, in canteens and in hotels. So because of access to unprocessed foods, and we have food delivery apps, you can order whatever you like, it comes to your home in minutes. And things like these are having an effect on our overall health and well-being. Here I have a table which shows the National Family Health Survey 5, which is a relatively recent survey, 2019-20. Figures from NFHS 5 for two indicators: body mass index, which is more than 25, which is considered overweight or obese. And the second is high waist hip ratio. So wherever I have marked it as star is above national average. So if you see here, this indicates that 23.8% of urban women in Assam have BMI more than 25, which means they're either overweight or obese. In rural areas, it is 13.6%. And if you see figures from NFHS 4, which is a relatively older survey held in 2015-16, this is definitely increased. The same holds true for men. So when you say 25.4%, it's 1/4 of your state population, and that's quite a lot, right? 66% women have high waist to hip ratio. So this essentially means there is fat around the belly. I will talk more about this in the next slide. And as you can see, the numbers are very alarming. So I think in the last few years, the concepts around obesity have also changed. The understanding of obesity has changed. Conventionally, when you imagine an obese person, the image that flashes in front of our eyes is of a person which is, so this is the westernized image of obesity, where you imagine a really heavy person with a round face, with a double chin, and like an overall fat body. I do not mean to body shame or anything here, but we need to understand the changing concept around obesity in India, which is now referred to as the thin fat obesity. So that is the point I'm driving across, where the notion of overweight and obesity as a disease itself has changed so much that Indian body type is now called as the thin fat Indian phenotype. So the thin fat, in fact, it is not even referred to as obesity. So the thin fat Indian phenotype means the individual is lean overall. The body is overall lean, but the belly is protruding out. So it may be the image is only for reference purpose. This may be a person of any gender, but the frame overall is lean with the tummy out, with the belly bulging out. That is called as the Indian thin fat phenotype. And this is being recognized as the newer forms of overweight and obesity and this is very dangerous because it is generally the fat around which is what is responsible for causing all the non-communicable diseases like diabetes, hypertension, cardiovascular diseases, and so on. I think it's also important for us to realize and acknowledge that in the NPCDCS, National Program for Prevention and Control of Diabetes, Cardiovascular Diseases, and Stroke, which is the National Health Program for Prevention of Lifestyle Diseases, does not have a programmatic component for overweight and obesity. There is something for diabetes, there is something for hypertension, which is essentially screening, blood sugar testing, blood pressure checking. We do not have focused program, and there is measurement of body mass index and measurement of weight ratio. But that is in terms of measurement. In terms of how to reduce it, we do not have a definite programmatic component as of now. Secondly,
Not clear. It
can't hear now. Can you hear me now?
Ma'am, sorry for interrupt. Your voice is echoing, ma'am.
Okay. I am only logging from one device. Is it audible now?
Dr. Radha, your words are not clear actually.
Okay, now is it audible?
Yeah, it's audible.
Yes, ma'am. Yes, ma'am.
So, like, did you hear me say that the Indian phenotype is recognized as the thin fat phenotype? Was that heard?
Dr. Radha, when you started, it was very clear. Now it is like overlapping of sound or sometimes distraction voice.
Even now, I don't have any.
Yes, even now.
Okay, then just give me a minute. Can you check now? Is it better?
Yeah, it's better.
Okay. Are the words clear?
Pardon?
Are the words clear? Is there echo?
No, there is no echo. Only words clear नहीं है. जो pronounce कर रहे हो, जो बोल रहे हो, वो clear नहीं आ रहा है.
Okay. I'm not sure what I can do at this moment. Two options, with earphones or without earphones. Is it any better now?
Ma'am, it's better without your phones.
Okay, great. Shall I continue?
Yes, ma'am.
All right. So did you hear me say that the Indian body phenotype, the Indian body type is called thin fat phenotype? Was that heard? I do not know at what point I became sort of unclear.
Yeah, please continue.
Okay. So I was saying that if there is any like just raise hand, just put it in the chat if it's still not clear. So I would move on to say that the Indian phenotype, which is now called the thin fat Indian phenotype, is essentially fat around the abdomen, and it is not like an overall obese person. And this is equally dangerous because it's all the fat around the abdomen which is responsible for causing all the non-communicable diseases like diabetes, hypertension, cardiovascular diseases, stroke, etc. In the National Program for Prevention and Control of Diabetes, Cancer, Diabetes, Cardiovascular Diseases, and Stroke, NEPCDCS as we call it, we have a screening component for all the diseases. We have screening for blood sugar, blood pressure, and there is BMI and waist weight ratio measurement. But in terms of how to address obesity, there is no programmatic component. Plus, the health programs that we have typically focus on IEC, which is information. Okay, I'm still not clear. Okay, I'm a bit confused now. I would request. Okay, can I request for my? I will log in from. Can I request for the slides being shared? Okay, let's just do one thing. Okay, is this better? Do you hear me?
Ma'am, I think you have to log out from one device.
आप एक काम कीजिए, किसी एक डिवाइस को अनम्यूट कीजिए।
हाँ, एक डिवाइस अनम्यूट है, तो फिर भी सुनाई नहीं दे रहा है। So I think if this is the last try, if it's not audible now, then I will take up the session in the end. Is it making any difference? Okay, this is the last check to see if I'm audible, or I will take the session after some time. Is it better now?
No, Dr. Radha, it is not better. It is same like no distraction and voice is
right.
not clear. Yeah.
All right. Then I think in the interest of time, I will take the session in some time.
Okay.
Hello. Sorry for the inconvenience. Now, in the remotest part, sometime during medical emergency, ambulance or doctor at times are unavailable. In order to reduce out-of-pocket expenses and medical emergency, teleconsultation has come to forefront. In 2020, during COVID, teleconsultation took a big foot forward. Teleconsultation helped when patients were home quarantined so that they could interact with doctors and at emergency. We have among us an experienced speaker who will give us a insight on teleconsultation. Now I would request Dr. Kakoti sir to take the session. Dr. Kakoti sir, he did MD in Gynae, life member of IMA, member of FOGSI. Dr. Kakoti sir worked at MMC Hospital as a gynecologist and later on retired as additional chief medical and health officer, Health and Family Welfare Govt of Assam. Dr. Kakoti sir associated with many social organizations, presently working as consultant health at Piramal Swasta, Assam. So over to you, sir. Thank you.
Thank you, Lotasri. Am I audible?
Yes, sir, you are audible.
You're audible.
Good afternoon and my namaskar to all of you. Lotasri, video is projected or not? Good afternoon and my namaskar to all of you. My heartiest thanks to all my previous speakers for their valuable and wonderful speech. I offer my heartiest thanks to the organizers and especially Dr. Radha for giving me this opportunity to talk few words regarding my clinical experience in NCD during TMC. Regarding NCD, I am at present dealing diabetes, mellitus, and hypertension. As we know, diabetes is such a disease that if once diabetes, it cannot be cured and can be prevented and can be kept under control. And for this, we should keep in mind 4 pillars as experts mentioned. Number 1, diet. Number 2, exercise. Number 3, drugs. Number 4, education. Experts say exercise is the silver bullet in the treatment of diabetes. If these 4 pillars can be implemented at grassroots level, I think we can bring diabetes and hypertension under our control to some extent. Now I like to highlight what I have seen in the ground level, what the beneficiary tells when they visit the service point for TMC, telemedicine. This telemedicine is done through our Sanjeevani, where our field staff held the camps. Field staff mainly composed of pharmacists, ANMs, laboratory technician, and computer assistant. Our staff do the RBS, check up BP, pulse, respiratory rate, and connect me via telemedicine. Generally, beneficiaries are mainly from shore area and general from rural plains, tribals, and also a section of tea garden. I am here citing few examples how beneficiary attend TMC. Sometimes history is very interesting, but sometimes for me is pathetic when I hear their history, the way of treatment they're doing. The beneficiary, when attend the service TMC center, service center, they comes with symptoms of diabetes. When I ask, since when you are suffering, they say, since some say 1 year, some say 6 months, some say 1.5 years. Have you got treatment? Yes, sir. 6 months back, I got treated. Where? From where? Hospital? No, sir. From pharmacy. Who prescribed? The so-called pharmacist gives the medicine for diabetes treatment. See, without doctor's advice, so-called pharmacists give the medicines like OTC drugs. Sometimes hypertension patients come. I ask them, or regarding diabetes, why you have come here now? Sir, I got relief. So since 6 months back, I have stopped. Now I am feeling dimness of vision and sometimes tingling. When I checked the RBS, it was found nearly 400. That means due to negligence of treatment, irregular treatment, the complication has just started. I immediately referred to the district hospital, because if I refer the PHC, then PHC will again refer to the specialist district. So directly I refer to the district hospital so that in a short time they get the proper treatment. And in hypertension cases, when I ask, what is your complaint? The dizziness. Since when? 8 months, 9 months, like that. Have you got treatment? Yes. Where from? From pharmacy. See, I astonished. Why you do not go to government hospital? Why you do not consult with a doctor where you get free treatment, everything free? The answer is no answer. That means some beneficiaries or a section of beneficiaries are reluctant to go to consult the doctor or to go to the government hospital to get the service. And pharmacists give the medicine, you will be surprised. They give directly beta blockers at a dose of 80 milligram. Beta blocker is given after checking the pulse rate, heart rate. So, they bring the cover slip. When my pharmacist sees, sir, atenolol 80 milligram, has he stopped? He has stopped since 2 months. It should be stopped. It should be tailored treatment in beta blocker. This is the way in the rural, very interior places they are going. When I ask why you have come here now, sir, I am feeling dizziness and sometimes weakness, sometimes उन लोग का भाषा में बोलता है माथा ज्यादा घूरता है, dizziness. Then I check the BP, it is sometimes 180 by 120 like that. So I give the medicines for 1 week and refer to the district hospital because he or she may need ECG or other help. Immediately, if I refer, say you go today or tomorrow, they will not go. So I give for 6 or 7 days at least to control the diabetes. Again, when some tea garden peoples come, tribal tea garden labor, their treatment is very interesting, the way they are getting treatment. Well, you have got hypertension, you are not taking medicine, why? No, sir, in the garden, we have to take medicine, we have to go to a hospital in the morning to take the medicine daily. And after taking the medicine, they go to work. Sometimes they miss, sometimes they neglect, they do not go. That means they are not getting in a proper way treatment. When in our service point comes, I say and give a dose of 1 month dose regularly to take and advise them to go to the government hospital. In the garden, this is happening. And in tribal, I have seen their garden people and tribal people more sufferer of hypertension. In garden people, they take red tea regularly, mixing with salt, not sugar. And I know that this system is starting since British days. And this is another cause, maybe due to high blood pressure. And in tribal, they took alcohol and pork. They fry it in a fire flame, mixing with salt. This may be the another cause of hello.
হয় স্যার শুনি আছো
Yes, sir, you are audible.
No, video to go এতিয়া কথা হেৰি video to go. Video is
No, we
no
can see
more,
you, sir. We can see you. Yeah.
You can see me.
Yes,
Yes,
sir,
sir.
yes.
You're audible as well as visible. Yeah.
Oh, then okay. I have seen nothing. These are my experience from tea garden areas. One interesting story I am telling. Before lockdown, I organized one health camp in a very interior place in Nalbari district. Have you heard? Hello? Hello?
Yes, sir.
Yes, sir.
Yes, sir.
My network is disturbing. One interesting story. Before lockdown, I organized one health camp in a very interior place in Nalbari district. One patient came, roughly 60, 65 years age. His main complaint is the one ulcer in a big toe in the foot and slight weakness. And that ulcer is not healing since last 2-3 months. He takes irregularly medicines from the PHC, probably antibiotic or local ointment, get relief. Then after a few days, again ulcer grow. Then I thought, I called his son. Today you go to Nalbari, check the blood sugar and inform me tomorrow. I gave my phone number. The next day he called me, sir, my father's blood sugar is 280 or 90, something like that. And they have started what drug? They told them metformin and glimepiride. I told that after 1 month, you call me regarding your improvement. The son called me after 1 month. Sir, my father's wound is completely healing. That means the ulcer is main cause is due to sugar in the diabetes.
Sir,
Hello,
sir, sir, namaskar.
namaskar.
Sir, মই ডিপিসি হয় পিৰামলৰ নলবাৰীৰ আপুনি নলবাৰীৰ কোনটো জায়গাৰ কথা কৈছিলে
Hey, it was about 3 years back. Mukolmar Usorat.
আচ্ছা মুকালমৰ ওচৰত
I will talk later on. Okay, 3-4 years back before lockdown.
okay 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 sir thank you
When I will talk with you later on.
Okay,
When
sir.
I have observed that some people are not still aware.
Yes, sir.
They are not aware what complications may arise, may happen due to neglect or not treating properly.
Yes, sir. Yes.
Sometimes I ask myself, is these things goes on, shall we be able to prevent diabetes, hypertension, or lower the incidence? A good awareness with some innovative way is required. To attract the people, only by holding awareness meetings, I think, will not solve the problem. During first WDF project in Assam, it is probably due to 2013 and 14. We tried to create awareness by holding street drama. The drama was held in the health camps, schools, to attract the people. The contents of the drama was to highlight what is diabetes, how it can be prevented, what complications will arise if we neglect or if we do not treat properly. I am not drama expert, but with my little knowledge, I composed the contents of the drama. And the drama took hardly 15 minutes. What I have observed, that we should talk to the Gaon Panchayats, local leaders, teachers, and they should be involved. Diabetes people should know treating diabetes is not costly, but not treating diabetes is very, very expensive. Regarding food for the diabetic patient, the diabetic patient should keep their food like their face. This message should go to the people, mainly to the interior place. But some people, beneficiary I've seen, they are very serious. They are sensitive also. But I think nearly 50% patients are still not aware what I have seen practically in the field. This is all about. Thank you all. Hello.
Hello. Thank you, sir, for an enlightening speech, which is very much helpful for us. And thank you so much for sharing your expertise. So, if you have any question, you can ask sir or write in chat box.
Hello, Rajendra Prasad here, Dr. Rajendra Prasad. Am I audible?
Sir.
नहीं सर धीरेन्द्र साहब नमस्ते
नमस्ते
आपका शॉर्ट प्रेजेंटेशन वाज वेरी स्वीट एंड वेरी क्रिस्प आपका प्रैक्टिकल एक्सपीरियंस से बहुत यूजफुल पॉइंट्स को निकाल के हम बताए हैं और आपका नाटक का रचयिता भी बोले बोल के भी वो सुन के भी हमको बहुत खुशी है मगर ये एक छोटी सी चीज है साहब 2 or 3 times you were asking are you able to see me But we are not seeing you. You are seeing an young man in 30s, very smart looking guy. हमारा धीरेन्द्र सब का है, उसके हम थोड़ा सा confuse हो रहे हैं.
Thank you, sir, for
Thank you,
your
thank
good
Good.
words, for your representing. How are you, sir?
Fine, thank you. Your
For a
presentation
long
was
time,
really
I have
good.
not seen you. Please
Yes,
come
yes,
to
yes.
come to Assam to see you.
So I would just like to come in here and mention that
I have expressed here what I have practically seen in the ground level.
so Dr. Kakoti sir and Dr. Rajendra Prasad sir are two of the most senior doctors affiliated with Piramal Swasthya, of course, along with Dr. Ranga Prasad sir also. So thank you, sir, for the session and for bringing a good balance of clinical insights into all the discussion of field projects and other aspects that we have been discussing. Thanks for bringing a clinical element there. Thank you so much.
Thank you.
Thank you, sir. Radha ma'am is available here, so I request ma'am to continue with her presentation. Thank you.
Yes, thank you. I think once again, I am checking whether I am clearly visible and audible.
Ma'am, now you are perfectly audible, ma'am.
Okay, okay, because I've logged in from phone now. So can we go to the slide before this? Yes, so I would also like to acknowledge the presence of Mette. Thank you, Mette, for coming all the way. And for coming here in amidst a busy schedule. Thank you so much.
Thank you.
So this session is about physical activity and why we must focus on physical activity, and also about how we got the community moving in Assam. We actually covered this, but I'll quickly touch upon this once again. So there goes a saying that obesity runs in the family when nobody runs in the family. Physical inactivity, which is linked to unhealthy diets and sedentary lifestyle, is a risk factor for overweight and obesity. And obesity by itself is a risk factor of diabetes, hypertension, cardiovascular diseases, and some cancers, as we all know. So gone are the days when obesity was a disease of the urban and of the elite. We are now seeing in the last decade or more than that, we are seeing increasing trends of increasing prevalence of overweight and obesity in men as well as women, young as well as old, rich as well as poor, and rural as well as in urban areas. So we are battling a two-sided problem here. Malnutrition at undernutrition on one side, and we have overweight and obesity on one side, and this is the dual burden of malnutrition that we are facing. Plus, we all have increasing predisposition to sedentary lifestyle, as we were discussing earlier. I think most of us are in jobs that require us to sit for a prolonged period. Agriculture is also being mechanized. Not too many people from rural areas are into, especially the young people, are not opting for laborious jobs. And I feel with the kind of urbanization that we have seen in the last decade or so, our access to processed foods, be it packaged or unpackaged, has increased tremendously. We have food delivery apps. We can order what we want in minutes. It's delivered to our doorstep. We want everything instant. And because of this culture, what has happened is we are seeing rising trends of overweight and obesity. So as you see on the right side, I will not go in detail into this because we saw this before the glitch, that we have a very high burden of obesity, which is measured in terms of body mass index for the overall obesity and in terms of waist hip ratio for the central obesity. So if you see the figures here for Assam, they are very alarming. So in urban areas, it's up to 25.4% men that are having a high BMI in overweight and obese range. And if you see the central obesity figures, waist hip ratio figures here, they are higher than national average. Wherever I have marked star is higher than national average. And these figures are in 50s and 60s, which are absolutely alarming, which require us to act now. Next slide, please. Yes, so with this, I think this is where the glitch happened. So the point here is that the concepts around overweight and obesity have also changed over the last few years. So the westernized picture that we always had in front of us whenever we imagined an overweight or obese person is somebody with a round face, with a double chin, and with like big body size, maybe holding French fries or something. That image may not be valid in India. And epidemiologists and scientists have now identified an Indian body type, which is called the thin fat Indian phenotype. So phenotype essentially means a body type. So the thin fat Indian phenotype is essentially a lean individual who may not be overall like obese or overweight, but they have a protruding belly, which means there is accumulation of fat around abdomen where overall the person is lean. And this is the body type that we see in most people around us. I'm sure you all will agree. And it is this fat which is around the abdomen which is actually responsible for causing most of the non-communicable diseases, be it diabetes, hypertension, cardiovascular diseases, stroke, and all the other NCDs. So with this, I would also like to draw your attention to some gaps in the current program with respect to overweight and obesity. So the National Program for Prevention and Control of Diabetes, Cancer, Cardiovascular Diseases and Stroke, NPCDCS as we call it, does not have a programmatic component to address overweight and obesity. So we only have screening. So there is screening for blood sugar, screening of blood pressure, and measurement of BMI and waist hip ratio, but we do not have anything to address it as such. The programmatic focus is only on IEC, which is information, education, and communication, with limited social and behavior change communication, which means you may have posters stuck about this in health facilities, or you may have a counselor who is talking about healthy lifestyle. But how much of this is translating into behavior change? Do we have behavior change programs? Do we have peer support activities or any other kind of activities which would really enable and empower individuals to switch to a different lifestyle for the proportion of obesity which is lifestyle induced? We also have many other initiatives, other different sectors, like we have the Eat Right India movement, which is under the food sector. We have Fit India, which is actually a program to Fit India, and Khelo India is a program to encourage young people to get into sports, for India to produce better athletes, but in a way that addresses physical activity. But do these programs of different sectors communicate with the health sector? Are they do they function in synchrony with the health programs related to non-communicable diseases? We do not know. The next point I want to make here, this is very interesting. Although we all know by now, in the last 1.5 days, we have been talking about NCDs. NCDs are the top causes of morbidity and mortality, top causes of sickness and death across India. But even at the state level, at the national level, do we have a program, a face for the program? Do we have a brand ambassador for the program? I do not think so. So we have Amitabh Bachchan ji, who is the ambassador for so many programs, for polio, for TB, and for so many other programs, right? And we also have Akshay Kumar and Ravi Kishan and so many other film stars who are, they are the ambassadors of various national health programs. But does NCD program have a face? That's a pity that one of the biggest programs and the program which caters to biggest diseases does not have anybody to endorse it. Similarly, although NCDs are so common, I don't think there is any home where there is nobody without a non-communicable diseases. Yet there is minimal creative representation in books, films, TV serials of people having NCD, of people dealing with NCDs. I think some old films of 80s and 90s only showed somebody getting a heart attack or on receiving a bad news, and that's all that we have seen. So I think that is also a conversation starter here. And again, I would also like to say that not many governments have been investing in NCD prevention as much as they are investing in screening of diabetes and hypertension patients. The possible reasons for this could be that prevention is a long haul. It takes minimum of 5 to 10 years for preventive aspects to show results in non-communicable diseases. And we have governments that change every 5 years. Moreover, the preventive measures are not very tangible. You cannot really measure them in terms of numbers or in terms of money. So it can be done actually, but it's a bit complex. And I think combining all these factors, we come to a realization that a lot needs to be done for overweight and obesity, and we are somewhere falling short. Next. So with this, I would also like to introduce what is called as the Global Diabetes Walk. So the Global Diabetes Walk is a global diabetes awareness program which is organized by World Diabetes Foundation globally. The aim of this program is to promote a healthy lifestyle and therefore prevent diabetes. So this year, under the Strengthening NCD Services in Assam project, so by this year I mean 2022, we organized a number of events. So while we had formal Global Diabetes Walk events in 4 districts, we went out of our way and organized a number of initiatives across districts of Assam to promote physical activity in some form or the other. Next. So we used a variety of approaches in each of these districts to sort of to ensure that the people are moving, to ensure that there is community participation and community ownership in all these events. And although I have a video to show you, I would like to give you a quick snapshot of what we did in some of the districts. Of course, there was something in every district, but I have only chosen the districts where we actually focused on physical activity and healthy eating as such. So in Guwahati or in Kamrup Metro district, we started with our workplace. We tried a number of things to make our own workplace. So when I say workplace, for us, it is Piramal Swasthya office. We tried to make our workplace active. So we had a Zumba session, we had so many awareness programs, we had competitions, we had a walk. So there Piramal Swasthya has 2 offices. So we got everybody walking in between the 2 offices. Secondly, we identified NCD champions. So the gaps that I said are at every level, state level, national level. So we had some prominent athletes, gold medalist winners from Commonwealth Games and Olympics as well as Paralympics from the state of Assam to be the NCD champions to advocate for healthy lifestyle in Assam. So we created local level champions. This was in Guwahati. In Dibrugarh, we actually tried a sports for health model where the district national health mission partnered with Department of Sports. So that is the district level health authority partnering with the sports department and actually rolled out a multi-sectoral program. Of course, this was only limited to one district, and it was the scale at which it happened was a relatively smaller scale, but we felt it's better it starts somewhere rather than us not doing it, waiting for it to happen everywhere. So the sports for health model was much appreciated, and the 2 departments actually you expressed great happiness. They were happy to shake hands and work together in collaboration in the future as well. And you heard about Jan Arogya Samitis sometime back in Sindhu's video. So Jan Arogya Samitis took ownership, the newly formed Jan Arogya Samitis took ownership and organized a cyclothon in Dibrugarh city. So this is what happened in Dibrugarh. In Lakhimpur also there was interdepartmental action where there was collaboration of the health department with the social welfare department. There were friendly football and badminton matches because, as you know, Assam and Northeast is so known for sports, especially football. And there was again involvement of Jan Arogya Samitis for promotion of physical activity through a walk, the Global Diabetes Walk. There was also a street play held during this walk for awareness of people about healthy lifestyle. Something we did in Dhubri was very unique and very interesting. You will see more of it in the video. So here we engaged religious leaders. So we engaged Muslim religious leaders, which is a majoritarian community in the district. And the Global Diabetes Walk as such that we had was flagged by a very eminent Maulana from the district. There was health promotion done at mosques. And believe me, we even announced about healthy lifestyle and diabetes screening, importance of timely screening, along with the azan in the mosques. That's the prayer that happens in the mosques. There was art competition in school on various themes related to healthy lifestyle. In Udalguri, which is also a tribal area, we had a yoga for health initiative, just like sports for health in Dibrugarh. In Shivsagar district, we collaborated with local NGOs that work for women to promote healthy lifestyle in women. And we had actually, it's girls and women. We had a football match for girls to get out and, get active. In Baksa and Golaghat, we had food exhibitions to promote locally grown food, which not just helps in balanced nutrition and sustained lifestyle, but which is also locally grown, easily available, and a sustainable way. And it's also good for the environment and climate, as we discussed in yesterday's session. So these were some of the initiatives. Of course, we had a number of other initiatives. We had programs in Dhemaji, Baksa, Dima Hasao, and a number of other districts. I have only picked these ones because these are more pertinent to physical activity and healthy eating. Next. So while a lot of it would be covered in the video, which is again made by my team from different districts, and special mention to Himadri there, the way forward for us is focusing on individual action. So this is also for us as people who advocate for non-communicable diseases and healthy lifestyle. I think we also have to focus on our own health and be a role model to the communities that we deal with. So individual action is of prime importance here. Community action, which in our case, we had involvement of Jan Arogya Samitis, Panchayati Raj members, local NGOs and other civil society organizations. There has to be focus on creating NCD champions, be it locally at village level, maybe somebody who has overcome an addiction, people at state level, people at national level. We have to also focus on policy advocacy and preventive measures so that governments take cognizance of this issue, and government also invests more in preventive action for NCDs. And I think we already have the National Multi-Sectoral Action Plan, NMAP, for common NCDs, which is a guiding document which was released in 2017. But I think it's about time that we translate policy into action and create local level models of multi-sectoral action for NCD prevention. So thank you. That's all from my side. I would be happy to take questions, but before that, we would have a look at the video which is a compilation of various activities that we did to promote physical activity and healthy diet. I would request the IT team to play the video. Thank you.
Thank you everybody for all your support. And I think this is also the credit of this goes to my entire team. So here's a big shout out to the WDF Assam family. I think it's only because of the work that we are doing in collaboration, the way we were able to function like a family more than like a team. I think these things were possible. I would also like to acknowledge Jurismita, our project manager, who is on maternity leave, but she is somehow constantly engaged somehow or the other. A special thanks to Mete from World Diabetes Foundation for supporting us through these initiatives. Thank you so much.
I would like to express my sincere thanks to Radha ma'am for their amazing presentation and videos. We have got lots of knowledge regarding NCDs, several precautions measures to prevent NCDs. So thank you so much, ma'am. Now I will request Priyanki Doctor to continue the next session.
Thank you, Latashri, and thank you, Dr. Radha ma'am, for your beautiful presentation regarding the NCD strengthening services across Assam and the GDW event mainly. So here I will move to our next presenter, Dr. Kirtana. So I would like to introduce Dr. Kirtana. Dr. Kirtana currently employed as Research Associate at Piramal Swasthya Management and Research Institute. During her engagement with the organization, she has been actively involved in implementing research proposals to address the health needs of tribal indigenous population of India as a part of the Tribal Health Collaboration Anamaya project. During this tenure, Kirtana have been part of multiple primary research studies in the area of sickle cell disease, traditional and tribal healers as key service provider. So now I would like to request Dr. Kirtana to take over the session. So welcome, ma'am.
Thank you, Priyanki.
Over to you,
such
ma'am.
a warm welcome. Good afternoon, everyone. Is my screen visible?
Yes, ma'am.
Okay. So today's presentation is about qualitative analysis of factors influencing medication adherence among TTREP and non-TTREP communities seeking care from mobile medical units of Assam. This is the plan of presentation, problem statement, objective, methods, results, and the conclusion. Coming to the study particular, evidently there is an increase in the global prevalence of non-communicable diseases, which is disproportionately affecting low and middle income countries. There are many contributing factors for such a greater prevalence. Of course, tobacco use, physical inactivity, harmful use of alcohol, or the unhealthy diets, or some of the major contributing factors which affects the prevalence or the incidence of non-communicable diseases. Thanks to our work from home or the online classes, which is also a contributing factor for one or the other form of NCDs. One such contributing factor, which is often neglected, is the medication non-adherence. To understand medication non-adherence, we need to know what exactly is the medication adherence. So the term, as it suggests, medication adherence is something. It is the extent to which a patient or an individual follows the recommendations that are provided by the doctors or the healthcare providers. So the opposite of medication adherence is nothing but the medication non-adherence, which significantly contributes not just to the disease prevalence or the complication, but also affects the quality of life of the individual. And it is now termed as an emerging public health challenge. In 2019, non-communicable diseases were estimated for 66% of all deaths in India, and 4% of it were from diabetes. Estimated prevalence of diabetes in India is 8.9% and pooled prevalence of 4.94% among the Indian tribal communities. 6.4% in men and 5.55% in women is estimated. There is varied prevalence of medication non-adherence, although a national average is not available. Some of the studies which are done in the pockets of India has reported medication non-adherence in the general population, varying from 45.4% in rural Tamil Nadu, 52.15% in Andhra Pradesh, and 56% in Uttarakhand. And in Sakwar, the tribal area of Maharashtra, 39.4% was reported. As we all know, tribal communities with their remote settlement or with the diverse health-seeking behavior differs from their non-tribal counterparts, and it is very essential to understand their treatment-seeking behavior and practices if you want to give a better healthcare facilities to these population. Access to medication or access to any sort of treatment is something that is very much important to assess the medication adherence. So considering this, NHM also strategized supporting mobile medical units as one of the key intervention so as to support the remote or hard to reach settled population. Mobile medical units, as we all know, due to its ability to penetrate to the remotest region and provide the healthcare services at their doorstep, is considered as something that's very assuring and that's very important for those population who are settled in remote or hard to reach areas. But with this access, with the access to the medications at the doorstep, their role in improving the medication adherence is something that is unexplored. Considering this, and also the paucity of evidence on medication adherence among the T-tribe and the non-T-tribe of Northeast states of India, the present study was designed with an objective to identify the ecological factors influencing the medication adherence among the T-tribe and the non-T-tribe diabetes beneficiaries of mobile medical unit serving areas of Assam. Coming to the study methodology, this is the overview of the study. So the present part of the study is the qualitative one, which is also a part of the larger mixed method study, which was conducted to assess the medication adherence and the factors influencing medication adherence among the T-tribe and the non-T-tribe communities who were seeking care from MMUs for hypertension and diabetes. So the present study was conducted in the mobile medical unit serving areas of Dibrugarh, Tinsukia, and Sharaidio. In-depth interviews were conducted to collect the data from the participants. Initially, 16 from T-tribe and 16 from non-T-tribe categories were decided to interview, but because of operational challenges, because of non-availability of T-tribe categories, 13 from T-tribe and 19 from non-T-tribe communities were interviewed. They were sampled to the study or selected to the study through purposive sampling. The data that was collected through the in-depth interviews were analyzed using Atlas TI software, and they were categorized into major and minor theme. Coming to the results section, the socio-demographic of the participants goes like this. The mean age of the participants was 57.65 plus or minus 11.25 years. Coming to the ethnicity breakup, 40.62% were from T-type category, 59.37% were from non-T-tribe, and the gender breakup is 37.5% were female, 62.5% were male participants. The education status of the participants was 21.87% were illiterate, 37.5% of the participants had lower primary education, 40.62% of participants had high school education. Coming to the thematic analysis, these are the major themes that was devised after collecting the data. The first theme being, I take medicine, I feel better, and I quit. The second theme is, if not MMU, we must travel far to get our medicines. The third theme, our villages suggest local herbs, I am trying them now. The fourth theme is, medicines are expensive, so I refill my medicines from MMU as they are free. The fifth theme is, mobile medical unit in our area provide a lot of support. Coming to the thematic understanding in depth, the first theme, that is, I take medicine, I feel better, and I quit. Many participants reported on and off consumption of medicine with the belief that they have recovered completely from the disease or the disorder in question, or they either have, there is a relief in the earlier symptoms or the discomfort that they used to feel, or both. So these kind of things or these kind of imaginations led them to skip their medicines. The skipping of medicines was not just reported because of those imagination or the beliefs, but also due to forgetfulness, fear to take medicine, the belief that long-term dependency on medication has adverse effects on the body, or they believe that it may lead to kidney or liver damage, unpleasant taste of medicines, medicines causing body ache, dizziness, and weakness, or whenever they travel or visited the relatives, skipping of medications was reported by many participants. Some of the participants also reported dizziness or weakness upon skipping the medicine, and that also led them to resume their medications. The second thing, that is, if not MMU, we must travel far to get our medicines. Distance can affect medication adherence significantly. For those communities who are staying in the very remote places, or in a place that is very difficult or hard to reach, traveling a distance of 5 to 7 or 10 kilometers to get the medications is definitely a bigger challenge. So this was reported in our studies also. Whenever they missed taking medicine from the MMU which served their areas, they had to visit these pharmacies or the various other facilities which was far from their settlement, and that definitely or significantly affected the medication adherence. This was further challenged by limited local commute facilities or the physical ailments or the other comorbidities, some of the participants who mentioned the comorbidities. And so for them, adhering to these medications, which are not easily available, for which they have to travel far, was something that was very difficult, and hence they skipped taking the medicines. For them, MMUs who provided the service at their doorstep was something like more assuring. The third theme, that is, our villages suggest local herbs. I'm trying them now. In a country like India, where the medical pluralism is significantly present, people try different type of medicine, but the irregularity or the skip pattern is also noted in those patients who mentioned that they are trying the folk medicine or the alternate system of medicine in a view that they will get a complete treatment in one session or two. So such myths should be busted. Education about educating the participants or educating the people about the medicine, the course of the medicine, and the effects or side effects, if any, should be given proper to them. Expensive nature of the medicines was also another reason which the participants reported for them to try this alternate system of medicine. Wrong dietary patterns. So some of the participants reported that they are skipping the medicine, and instead of the medicine, they are practicing the diet or they're keeping track of their nutrition things. But this is something that was unmonitored. So unmonitored dietary practices can definitely harm the patients. So such practices should also be, such participants or such patients should be enlightened about the different, the right practices of dietary patterns or the physical activities as well. The next theme, that is the medicines are expensive, so I refill my medicines from MMU as they are free. The fact that lifelong consumption of medicine is not just a person's burden, but it is also a family's burden. So for people who are mostly depending on their daily wages, for them, traveling for a farther distance for a regular review or follow-up is something that cuts their daily wages, 1 day of wage. So for them, their daily wage is something that's very much important. So that they prioritize their daily wage instead of the regular checkups or the investigations, the regular follow-up that is required to understand the disease or the health status. So that is something that's again significantly affecting the population, and the participants were also found to report the same thing. And for them again, MMUs which provided the cost free or the affordable or the periodic availability of the affordable medicines definitely played a major role, and the participants reported that this is something that helped them to maintain their medication adherence. And some participants also reported that there is a frequent medicine stockouts at the public health facilities, and that has also necessitated them to depend on the MMU services that are being provided to them. And the financial challenges again has also burdened them to get that the medicines from the pharmacies, and also as discussed in our previous sessions, the fear of self-medication is also there. The next theme, that is mobile medical unit in our area, provide a lot of support. Periodical access to the healthcare services and not just access to the medicines was provided by this MMU. So the participants or the community where this mobile medical unit was serving, it mainly depended on those services to understand their health status or the disease status, and also to procure the medicine. Along with that, the MMUs provided the quality care, the regional language conversation, which helped them to understand the things, which helped them to share the concerns, whatever these patients had with the MMU service provider. For them, this is something that was more comforting. And many participants also reported that since the MMUs are providing the services at their doorstep, it is convenient for them to get the blood sugar levels checked. These were the major themes or the major findings that we understood from the qualitative arm of the study. So to conclude this, to put all those findings in the nutshell, although we wanted to understand if there are any differences in the TTRAB and the non-TTRAB categories, to our surprise, similar results were reported in both the TTRAB and the non-TTRAB categories of patients. Medication adherence cannot be promised with just access to the medicine. So, but to address a disease burden or the complication, definitely it is the medication adherence that is something very much important. So to ensure that, there are many other factors, there are many other players which influence these medication adherence. For example, the individual or the patient factors. Say, for example, the hesitation or the fear among the participants or the communities to take the medicine, or the fear or the half knowledge that the long-term consumption of medicine can harm the body, or the myths that 1 or 2 session of medicine can cure the disease or the disorder in question. That is something that contributed to a great level, and that influenced them to stop the medicine or to skip the medicine for a specific number of days and then start again with the medicine. So such irregular or on and off pattern was something that was reported by almost all the participants. So these patient or the individual factors should be considered when we educate them, or when we provide awareness to the community about the disease diagnosis or the disease treatment related things. So provider factors. The second factor that influences the medication adherence is the provider factor, like the uninterrupted access to the cost-free medication with the patient-friendly environment or the healthcare that again play a vital role in medication adherence. This is something that also should be ensured while giving treatment to the patients. Along with this, it goes without saying, the generating awareness or the IEC activities that is already in place should not just focus on the diseases or the diagnosis, but it should also focus on the adherence to the medication, or also explain about the different complications that may arise if the medication adherence is not ensured, or if there is any skipping that is happening with the intake of medicines. Behavior change communication to ensure medication adherence is definitely needed. And last but not the least, integration of patient and the provider factors with the healthcare organization factors. That should be ensured at all levels of the health system. When we say healthcare organization factor, it refers to the access to the affordable medicine, availability of this access, uninterrupted access, or the emergency care, or any healthcare facilities, the physical infrastructure, functional healthcare facilities are needed, along with the consideration of the patient and the provider factors. Thank you.
Thank you, Dr. Kirtana. So thanking you for your beautiful presentation. So we can now move to our next presenter, Dr. Renu Bala. So, hello, ma'am. Hello, ma'am. Am I audible?
Yes, yes.
Yeah. So now I would like to introduce Dr. Renu Bala. Dr. Renu Bala currently working at Homeopathic Drug Research Institute, Lucknow, Uttar Pradesh. Dr. Renu Bala worked as a research officer at Regional Research Institute for Homeopathy, Guwahati, Assam. Regional Research Institute for Homeopathy, Imphal, Manipur, and as a research associate at Clinical Research Unit, Siliguri, which included screening and treatment of patients with lifestyle disease under NPCDCS program, also worked as medical officer under NRHM in Uttar Pradesh. So I welcome you, ma'am, for this second Northeast Diabetes Conference, and over to you, ma'am, for your session.
Okay. Thank you for introducing me. Am I audible?
Yes, ma'am, you are audible.
Okay. Thank you. And I would like to thank Mr. Madhu Raghavendra ji for approaching me for this paper presentation today. Actually, one online conference is also going on, departmental one. So I won't take long. So please allow me to share my screen first. Can you please allow me to share the screen?
Yes, ma'am, you can share your screen.
It's not allowing, I think. Madam, it's not allowing.
Ma'am, wait for 2 minutes. We are checking. I request IT team to check.
It was Dr. Renu is the host.
Ma'am, sorry for this inconvenience. So please wait for another 3 minutes.
Okay. Hello.
Hello.
Utpal, can you please make ma'am the co-host?
Yeah, I think it's working now. Fine. Is it visible?
Yes, it's
Yes, ma'am,
visible,
your
Dr.
screen
Renu.
is
Yes.
visible.
Is it visible?
Yes, it's visible, Dr. Renu. Yeah.
So I'm extremely pleased and thankful for this opportunity to share one of my research paper on the second Northeast India Diabetes Conference. I have a very special connection with Northeast. I would like to tell that I have been to Guwahati and Imphal for over 5 years there. The topic of today's conference of NCD and tribal health, I think it's also very relevant in present scenario, where we see a huge surge in these kind of cases related to diabetes, hypertension, and other NCDs. So this one study is among other 9 observational studies, which I and my research team of Imphal, we conducted these studies during COVID-19 pandemic, when there were varying degrees of quarantine and lockdowns and containments were there.
Madam, could you please make it full screen?
Yeah, it's full screen, I think.
वो slide show में जाके just if you could
make a slideshow from it.
ये insert के बाद design के बाद animations उसके बाद slide show ऊपर.
Yeah, just press F5.
Is it not visible full screen?
No, it's on like that. We can see the presentation, but it's not on the presentation like slideshow mode.
Oh.
Like if you could, yeah. So
But,
your slideshow.
Yeah, it's full screen actually on my screen.
Okay, no worries. Yes, thank you. Yeah.
Now, is it full screen?
No. I think, ma'am, you'll have to stop sharing, make it on slideshow, and then share your screen.
Okay, just wait. Now?
Yes, okay. I think we may continue. Yeah.
Okay. So this study got published in Diabetes and Metabolic Syndrome, which is an Elsevier journal. It is a peer-reviewed journal, in which we measured the self-care practices among the diabetic patients who were visiting the OPD of our Regional Research Institute for Homeopathy in Imphal. Are the slides moving?
No, they are not. No.
Actually, it's working fine here over my screen. But,
Now it's moving. Now it's moving. It's okay. There's a part of this online thing. It's okay. Yeah.
Yeah,
Now we can see the introduction.
were going on since yesterday. There was no net and all. So
Now we can see introduction. Yeah.
okay,
Thank
okay.
you.
So diabetes mellitus, we know, is a metabolic disease which is characterized by chronic hyperglycemia due to defects in insulin secretion, insulin action. So the burden of diabetes, it has steadily increased in India and across the globe over the last few decades. The global diabetes prevalence in 2030 is estimated to be 10.2%, which will be rising to 10.9% by 2045. So we can say that we can ascertain the chronicity of these conditions. Even though COVID-19 had varying degrees of illness, the mortality rate was low in healthy individuals. However, the patients who were suffering from diabetes, they were associated with severe diseases like ARDS and other diseases like that. So there was a large pool of undiagnosed people with diabetes in India. It was recommended that blood glucose check should be made over 30 years of age who had COVID-19. Among the geriatric population also, hypertension and diabetes poses a risk for heart attack, stroke, kidney failure, vision loss, and peripheral nerve damages. Diabetes is now common in developing countries, including India, and it has a big impact on mental health. The reason being the burden of financial and physical sufferings that were enough to cause depression among the patients. So anxiety and depression are commonly found in patients with diabetes, and it has a big impact on the health-related quality of life. So good glycemic control, we can say it is an important factor in preventing the complications which are associated with diabetes. And it can only be attained by adaptation of good lifestyle modifications, including balanced diet, exercise, proper sleep, and psychological well-being with medical guidance. It was seen that self-care for diabetes patients during COVID-19 had been a great struggle physically as well as mentally, due to the impact we have seen due to social distancing at that time, quarantines, frequent lockdowns, and various containments in different areas. Few main problems which were faced were diminished physical activity among the patients. There were restrictions in food supplies, which compelled the patient to alter their food habits, leading to uncontrolled hyperglycemia. There were problems of medication and difficulty to access the medical consultation for routine checkups. It has been known that diabetes and hyperglycemia, these are independent predictors for death and morbidity in the COVID positive patients. So metabolic control may improve the prognosis in these patients. During the COVID-19 pandemic, regardless of the severity and the duration of diabetes, it was crucial to aware patients about self-care, maintaining weight, reducing the intake of saturated fats, quitting alcohol, smoking, increasing the physical activities, nutritional counselings to be done, self-monitoring of blood glucose, improving their medical adherence. Considering the mental health issue as a major health concern during that time, it was indispensable for us to study how diabetic people are coping with such a major disaster and to understand their mental health status. Therefore, this study aimed to assess the impact of COVID-19 on psychological well-being and self-care practices among those patients during that period of the pandemic. Are the slides moving?
Somehow no. Yeah.
Somehow no. Let me see if I could correct this.
Now it's okay. Yeah, methodology. Now it's a
Yeah, it's going on a little bit late, I think.
Yeah, that's fine. Sure.
Mm. So our methodology included a cross-sectional study. We conducted the study from 3rd August to 28th August 2020 among the diabetic patients at the OPD of an institute in Imphal. The participants above 18 years of age were included in the study who agreed to participate in the study. The estimated sample size for this study was calculated to be 101 subjects. We used EpiInfo software with a confidence level of 5% of significance. The patients were recruited on site using the assessment questionnaires. The study was approved by the Institutional Ethical Committee of our institute in Imphal. Yeah. So the participants were informed about the background, the objectives of the study, and the confidentiality of the study through the informed written consent form. The self-reported questionnaires I'm talking about, we included 2 validated skills, the summary of diabetes, self-care activities with 10 questions. It is a brief self-report questionnaire of self-management, and it included questions about general diet, specific diet, exercise, blood glucose testing, foot care, and smoking. The other questionnaire we used was Kessler Psychological Distress Scale. It is a simple measure of psychological distress, and it involves 10 questions about the emotional states. Yeah, about the statistical analysis, the descriptive analysis of this study gave frequency, percentage, mean scores, and standard deviation of response under each section. We used analysis of variance and t-test to find any significant difference in between both the scales depending on the demographic variables. The p-value was capped at 0.05. So the number of subjects we recruited in this study were 108. The maximum participants we found were between the age of 46 to 55 years. They were male, married, and lived in urban areas. Majority of these participants, they did not take any prophylactic medicine for COVID-19, while we found that 34% took homeopathic medicine as a prophylactic measure against COVID-19. I'll just wait for the slides to move on. Yeah, this is a table of demographic variable of our result, which I have just discussed with you. Yeah. So the results of this SDSCA questionnaire showed that a daily healthy eating plan was followed by 77% of our participants, whereas 45% of the participants had fruits and vegetables, and 48% of them consumed high-fat food. Daily physical activity for at least 30 minutes, it was found to be performed by 50% of the subjects, and 24% of the participants, they were engaged in specific exercises like swimming and walking. An important finding that came out in this study was that 85% of the subjects, they had not tested their blood sugar levels. So the participants showed poor food care behavior in 83%. Out of the participants, 99% they did not take any part for the smoking. If I talk about the psychological aspect of the participants, anxiety and nervousness was observed in 32%, and a feeling of depression, it was experienced by 15% of the participants. So diabetes self-care, it has become an important aspect, as the majority of day-to-day care in diabetic patients, it is handled by the patients as well as their family members. And it includes a range of activities like self-monitoring of their blood glucose levels, eating a healthy and low saturated fat diet, regular physical exercises, and checking their feeds, which is a very important factor. So this study aimed to identify the self-care measures which were adopted by these patients who visited our institute's OPD during the pandemic. Diabetes was the condition which is reported to be most impacted by the reduction in healthcare resources due to COVID-19 pandemic. And several other studies have also reported a greater risk of severe COVID-19 in diabetic patients. So from this study, we highlighted that education among the patients about the importance and use of self-testing their blood glucose level is required. Patients must be educated and sensitized on this aspect to keep their diabetic levels, hyperglycemic levels under control. So diabetic foot syndrome, it is also one of the severe complications we found in the patients due to increased plantar pressure, which is resulted from the undetected mechanical traumas to their lower extremities. It is also noteworthy in this study that foot care among the diabetic patients, it came out very poor. The majority of the participants, they maintained very good dietary compliance along with everyday intake of fruits and vegetables. Side by side, the intake of high-fat foods was also seen among half of the patients. Indoor exercises like body weight exercise, jump rope, yoga, these exercises can be safe and simple, and they can easily implement them in their daily routine. And these exercises can help in preserving the fitness levels of these patients. It has been postulated that some activity is better than none. So I would urge the patients, I still urge the patients to do some kind of activity, at least daily, on a daily basis. Half of the participants in this study, they were found to be physically active, though specific exercises as walking, they were limited to a very small group only. Regular exercise, we know, is the fundamental, not only for the glycemic control, but also for the psychological well-being. Since regular physical activity, it reduces stress and anxiety. It improves mood and sleep quality. Surprisingly, people in this study, they were not found to be too anxious about the COVID-19 situation, and they were found to be very optimistic. Participants in this study, they typically reported good level of dietary self-care, followed by exercise self-care. Poor level of self-care was reported only for foot care and blood glucose testing. This study has few limitations also. First, being a cross-sectional study, the results are based on single observation only. So they do not factor in the effect of prolonged restrictions due to the pandemic situation. Secondly, the data which we collected were from the residents of Manipur state only, and it might have been affected by the cultural norms. Thirdly, a convenient sampling method was used, and it may bias the data. It may not be representative of the whole population. Despite these limitations, the present study generated robust evidence on dietary and exercise regime among the diabetics. During the pandemic, there has been many lifestyle changes noted in all people with diabetes. Taking care of diet and physical exercise regularly could help the patients maintain good glycemic control. Since people with diabetes seem to develop more severe complications with COVID-19 infection, they should take adequate care of their blood glucose levels. This study highlighted the fact that people with diabetes should monitor their blood glucose levels more often along with their food care. So this is all about this study. I hope it was not boring. As I heard the last sessions yesterday, there were some music pieces in the last session I heard. It seems that this particular conference is a true amalgamation of knowledge, music, poetry, which we in our research field, we do not come across actually, usually. So this was a unique kind of experience for me. So I would thank again Madhuji for approaching me and giving me this chance to be on this platform. I would congratulate Dr. Radha also and their team for organizing this kind of conference. And also I heard her presentation also. You all have given such a nice initiatives you have taken for promoting this healthy lifestyles and promoting exercise among the general public, which we usually can't do on a larger base. We do only on a OPD base, or we do on some small population. But yeah, I saw the video. It was just wonderful. So congratulations to your team and best
Thank
wishes.
you. Thank you, Dr. Renu. It means a lot. You have been so observant apart from presenting the glitches and taking time out of departmental meetings. I mean, and this is why I wanted to include Ayush also, and your study was such a enlightening study, because although it was cross-sectional, the fact that you kind of came across, and psychological problems are something as like as a part of NCDs also, they are coming up as one of the key factors right now. So thank you for being observant. Thank you for being with us here today. And thank you for making the presentation. It was really nice listening to you. And apologies about glitches on our end. And slow internet is something we have to, it's like the Schrodinger's cat. You are there, but you're not there. But despite that, it was a lovely presentation. Thank you. Thank you. And also from Manipur, now we move on to, because we are running out of time, we move from Manipur to Meghalaya. We invite Dr. Garel Ryan. And I wanted to bring in the perspective, because these are institutes, not only institutes of repute, and he is, Dr. Garel can be, are you here, Dr. Garel?
Yeah, I'm here.
Yeah. So thank you for coming in. So Dr. Garel is, Dr. Garel Ryan is an assistant professor from Northeastern Indira Gandhi Regional Institute of Health and Medical Sciences. It's an autonomous body under Ministry of Health and Family Welfare. The importances of such places is that, apart from the field and the community we have all been speaking on, these institutes of repute are always thronged by many, many patients from across the state, not only from across the state, also Northeast. So they have a very different view as practitioners, as being part of colleges. So Dr. Garel, I request you to take over and give some comments on your experiences from Meghalaya.
Thank you, Mr. Madhu. At the outset, I would like to thank the organizers of this second Northeast Annual Diabetes Conference for inviting me to speak to all of you here. Though I was informed at the last minute, so I don't really have a presentation as such, but I would just like to speak on my experiences. Although my topic is on non-communicable diseases and my experiences with them, however, I would like to focus more on diabetes, as it is the main theme of the conference. NEGRIMS, being a tertiary healthcare institute in Meghalaya, not only receives referrals from the local population, but also from other neighboring states. And we all know that we are facing an epidemic of diabetes mellitus, and similar to the challenges faced by physicians of other states, we are also facing similar issues here as well. And I will discuss about the issues that we are facing here briefly. The first issue that we usually face out here most commonly is regarding insulin therapy. Patients out here, they are, as compared to other states as well, they are reluctant to use insulin as a form of management, as they would rather prefer to take oral medications instead of taking some injectable medication, because it's cumbersome, and as you can all understand that taking an injection twice a day or maybe thrice a day, it's not feasible for them. So that's one of the main challenges that we face here, in that we are trying to convince them that insulin therapy would be best for them. At times when we are able to convince the people to take insulin therapy, we find out that like they do not have any access to a refrigerator, because insulin being heat sensitive medication, we have to keep it in the refrigerator. We can't just keep it in room temperature. So that is one of the issue that we face with regarding insulin therapy. Another issue that we usually face here is like based on the guideline-based therapy, as per all your diabetes association guidelines, whatever guidelines they advise regarding high-risk patients, regarding drugs such as your SGLT2 inhibitors or your glucagon-related peptide analogs, they are indicated as per theoretically, they are indicated. However, the profile that we get in a government institute and a government setup is not someone who can afford such medications. So even if you wish to prescribe such medications, because like theoretically on the basis of guidelines, they are the medications that will help the person better. However, there is like no guarantee on the patient being adherent to such medications due to the financial constraints. Another issue that we usually face here is regarding the medical nutrition therapy. Again, theoretically, as it has been discussed in a previous by a previous speaker, we all study regarding low glycemic index meals, and like not taking ultra processed meals, and how they form the basis for medical nutrition therapy. However, the same reason that we face with guideline-based therapy, we are facing the same challenge here as well. We all know that ultra processed meals are cheaper and easier to access, and hence they are very difficult to like ensure that they are not part of their daily diet, or they are not present on the dinner table of the patients. And we all know that these ultra processed meals are one of the main contributors of non-communicable diseases as a whole. And the advantage of these meals is that they have a good shelf life. They are easily to produce. They are very cheap, easily accessed by the patients. However, if you ask the patient to get a low glycemic index meal, it's like very difficult. It's like more expensive compared to what the normal ultra processed meals are. And so, as you must have concluded from what I've spoken so far, the main challenge we face is really related to the socio-economic status of the population. And I would like to state that these issues are not unique to the people of Meghalaya or the Northeast region as a whole. Before working in Nigrims, I was also working in another government tertiary healthcare institute in Delhi as well. And we note that like the same issues, that the profile of the patients that come to the to a government-based institute, they are like they belong to a different, slightly lower socioeconomic strata, and hence all these issues are faced by all. These challenges are there for all physicians, not only in the Northeast but also elsewhere in the country as well. At the same time, there are some good news and benefits for the patients that come to a tertiary healthcare institute. An advantage of being in a tertiary healthcare institute is that we have the ability to screen, diagnose, and manage all the microvascular as well as the macrovascular complications of diabetes mellitus. And we also provide patient awareness programs in association with other departments as well, such as the ophthalmology department and the dietetics department, for a holistic approach towards treating diabetes. Another thing is that like the tribal population in this area, they are adherent to medications and to follow up, and they usually take the medications and they come for us to for follow up. But again, the same issues that are there that contribute to the lack of follow up, namely that the socioeconomic status. If we start a patient on insulin therapy or some guideline-based therapy, it becomes very difficult, and then they tend to go away and seek a second opinion from some other place, maybe from some private practitioner or some other place. So the crux of the issue is that like we need to create more awareness in order to ensure that create more awareness in order to ensure that the people are aware that that they can take insulin, that insulin therapy or this some of these guideline based therapy will help them, but at the same time we also need to uplift them as a whole also, so that they are able to gain access and to such therapies as well. And regarding creating awareness, just like last year on World Diabetes Day on the 14th of November, we had conducted an awareness campaign as well here, as well as a screening camp for the patients who had come on that day to our institute. That's all. Thank you.
Thank you, Dr. Garrel, for sharing your insights. And these are indeed very important insights, although anecdotal some parts, and because you as a practitioner are practicing, as you said, in a tertiary care center, and the fact that, I mean, patients are not that very conducive to using things like insulin is a very important insight going forward. And definitely you are running awareness campaigns too. So it makes it going forward also, if you're looking at Meghalaya, it makes us a good collaboration point there. But thank you for coming in at the last minute and sharing some of your thoughts from practicing at a place like Nigrims in Meghalaya. Thank you. And with that, we move on. And as Dr. Garrel was speaking, and yesterday also we had a small session from Arunachal on traditional healers, and which is very important when we speak of the North, at least in the Northeast, where the trust of the community lies. As he was saying, patients also move towards seeking more second opinion, third opinion, fourth, fifth, and so on and so forth. But always, especially in the remotest parts, the first opinion is also the traditional healer. So our last speaker today is a very short comment talk by a doctoral student from Tezpur University who's researching on traditional healing in Assam, Ms. Leena Basak, accompanied by Professor Amiya Kumar Das, who is a associate professor at Department of Sociology at Tezpur University. He has worked with UNICEF on various health projects, and he has overseen some doctoral students as well. So we welcome both of you. Ms. Leena, are you here? Yeah.
Am I audible?
Yes, you're very audible. Yes.
Shall I start?
Yes, please.
Okay. So first of all, thank you for giving me the opportunity to speak over here. And basically, I am a research scholar from the Department of Sociology, and I am researching on the traditional healing practices that has been performed in Assam. Especially, I have done in context to the Tea tribe community. So first of all, before speaking about traditional healing practices and the experience that I have personally faced in the field, I would like to say about what is traditional healing practices. So traditional healing practices means the practices which are done in order to heal or cure someone's health, and it aims for the overall well-being of a person. It is a holistic approach which takes into consideration the values, beliefs, social interaction, and spiritual orientation of a person. According to WHO Global Center for Traditional Medicine, it says that 88% of all countries are estimated to use traditional medicines such as herbal medicine, acupuncture, yoga, indigenous therapies, and others. So basically, I have divided these traditional healing practices into two parts. First of all, the traditional healing practices which we do at our home, like on regular basis, or like the practices which we have learned from our families or like our neighbors from generations. Like for speaking about the traditional healing practices that we do at our home are like for diabetes we eat giloy, this giloy juice, which is known as the heart leaf monseed, which I have personally also seen that the stem of that giloy is soaked in water, and in the morning it is like drunk or consumed in order to control diabetes, or like fenugreek seeds. They are also used for controlling diabetes. like various other traditional practices also are done. Like we can call this as herbal sort of thing which we used to consume in order to like cure our health or like control our diseases. Basically, I am researching on traditional healing practices. So I would like to focus on the rituals and the practices which are performed by local people. And as I mentioned, there are two types of healing practices. First of all, I told that it like we perform at our home, and the other is which is done by the traditional healers. So the traditional healers are those persons who are like recognized from the community, and they conduct healing practices in their community. So if we try to define traditional healers, they are someone who is recognized in the community, and like he lives in the community as competent to provide health care by using vegetables, animals, mineral substances, and other kind of substances which are based on the social, cultural, and religious background, as well as prevailing knowledge, attitude, belief regarding the physical and mental and social well-being and the causations of disease and disabilities in the community. So this was like what is traditional healer. So the traditional healers are of different kinds. Like they are like every healer doesn't perform the same kind of activities. Like some of the healers are like herbal based, like they use herbal medicines in order to cure people, and likewise there are spirit based healers like who use divination and all in order to cure people. And witch finding, or like we can find like healers who uses all these three kinds of remedies in order to cure people. And we also find there are bone setters who used to like help the people who are having fractures and other kind of things regarding their bone, and they use other some kind of practices in order to fix the bone. And there are traditional birth attendants. So these are some of the like traditional healers who help the people of the community in order to cure their like disease or ill health. And basically these all healers are based on the faith healing practices or the faith-based practices. So as I have told about like the faith-based practices are performed by the healers, they are known as diviners. So diviners are the people who are like we call like who are connected with the God, or they claim that they are connected with the God, and they get the idea from them, or the methods in order to treat or the techniques they learn from the divine power, and they practice this in the community. And some of the healing practices are like they have learned from like the by birth they have learned, or some even say that in their dreams they have like got this power of healing. So this kind of practices are still like prevalent in Assam, which I have found in like tea community people, and also I have done some research on other communities. So I can like say that this kind of practices has been going on, and there are cases, some of the cases which I want to like share of the healers, which like they have cured the people, or they are like doing for the people. Like there is an incident which I have like found when I was talking with the people who were like coming and visiting the healers. So I was nearby them and asking like, why do you like come, and why do you prefer them, and like what are the kind of problems that you are like healthcare like health problems or health issues they are facing, and they are coming over there. So like one of a child who was coming with their parents, like they said that he was not intaking chicken, and like his favorite food was chicken, but he was not able to have it because they don't have any explanation that why he is not able to have certain kind of food, and like taking all kind of food. So they were going to the healer, and like the healer, he like took a piece of like chicken, and like he chanted something, and showed that chicken like that meat, piece of meat around the fire, and like he told them to cook and like have it. And after that, they were, like the child was able to have the food after doing that. So there were various such cases in which I have seen that the people were able to like get cure from those healing practices. And regarding that treating of jaundice, also I have seen that there are some of the faith healers, different faith healers use different kind of healing practices. Like some of them use like a fern-like leaf for curing jaundice, and some use like a copper ball, and they used to put water and oil in the copper ball, and they like used to do some kind of ritual in order to remove jaundice from their body. So there are different kind of practices they have been practicing, and like people used to believe on them. So like this kind of practices that have been prevailing, it could be said that because of their belief system, which like it's continuing from generation, like from generations. And so they are like wanting it to like take over those practices. I have already found, like I have found that the people who like, it's not every time that they are not having that affordability kind of problem, like they cannot afford the biomedicine, or like they cannot go to the hospital because of the distance or other such factors. But there are also factors like of the belief that they are having. They prefer to use those kinds of healing practices, and traditional healers, they prefer to go to them. And there I have also met a bone setter. Like when a person went like to the bone, like first he went to the hospital for like diagnosing his like what's the condition of his like bone. He had an accident, so like his backbone was like completely broken, and like it like doctor told that like the doctor like put his hands up that, oh, I can't help with this, and I don't want to take the risk of like curing this if it creates any problem later. So the person, he went to the this bone setter, and like he after like 2-3 months of taking that the bone setter used to give some kind of paste over that area, and he used to cover that area. So after doing that for 2-3 months, he was able to recover. And like when these people who goes to the healer or these practitioners, when they go to them, and like they're like when they are able to like get the belief, they used to spread and like tell to others also, for which this belief is like passing from one generation or one people to other, by like knowing and understanding that the other person have got cured from that. So the others can also like rely or depend on it, or like trust on it. And I would like to tell about the traditional birth attendance. So here I have also seen traditional birth attendance, and I would like to share a small case. Like a woman was like, she had did all her like taken all her injections and everything from a hospital. Like she was taking all her care through the biomedicine practices, and like suddenly her water broke, and like she had to emergency like rush to the hospital. And like what happened, she was not able to go to the hospital, reach out to the hospital, because there was no one in her place, like at her home. So like a healer, the traditional birth attendant was by her, near her house, and she took her help, and she delivered the baby. But like, so it's not always the case like you don't believe the biomedicine, but it's also like the emergency kind of situation what you face, like it also forces, or it makes the people tend to use this kind of health or the healing practices or the traditional practices. With like,
Lena, thank you for your full comment, and we are running out of time. And but
I'm
there
just
are,
compiling it.
yeah, please, in a minute.
Yeah, 2 minutes. So as this session is especially regarding diabetes, So I want to share one incident related to diabetes. A person who was like totally fit and fine, he suddenly lose his what to say, like mental stability. Okay, like later he came to know that it was his diabetes was like the level it rose to more than 500, and like he was losing his mind. He didn't know what to do, and like his family members were also like unaware of like what to do next, and like how he did completely lose his mental stability. So people are so from this case I came to know that people are not completely like aware of the symptoms, or uh, this case that I'm speaking of, it's a middle class family, so it's not that backward kind of family that doesn't know about diabetes, but they are not aware of like what are the symptoms. So I have found the people in the field, like in tea community also, the people are not aware of the symptoms, and they don't know like how to go and diagnose with that. So it would be better that more kind of this kind of like initiatives are taken in the backward areas, or through some kind of processes that the initiatives to like spread awareness on its symptoms. Okay, thank you so much.
Thank you,
I'm
thank you,
sorry
thank you,
for
Ms.
taking
Tina.
so much of time.
No. The thing is, we are running out of time. But this is such insightful pieces from the field, and especially diabetes, as you were saying, the awareness definitely is there, and I'm sure the whole of WDF and the whole team is working slowly, and eventually these, and even Tatha is here, Tathagata, who's a part of our researcher looking at traditional healer, and many other teammates who are looking at tradition, and we want to, as a part of Anamaya, also consider that. And because we understand when we are working in areas like Northeast, it is one of the, and I say that with utmost sincerity, that there are many kinds of belief and many kinds of people treating at the field level. Thank you for documenting for all behalf of all of us. And thanks to Professor Amiya Kumar Das also for being here with us. And I hand over the session to the conference secretariat and Dr. Radha.
Thank you. And I would like to check once again if I'm visible and audible.
Yes, visible and audible.
Okay, I think things have to go wrong only when it's your session. All other time it's perfect. So anyway, we come to the end of day 2 of Jaagar, and I would like to propose the vote of thanks. Although Madhu has been referring to a conference secretariat, I think he is also a part of the conference secretariat, and this vote of thanks is on behalf of all of us. So Jaagar, so the feedback form is already in chat. We have pasted it many times in chat, and I would still post it again and request all of you to share your valuable feedback with us. And while I propose the vote of thanks, I also suggest you wait for a couple of minutes. We really need to have a good picture before we end this conference. So, I mean, what do I say? I don't have a formal speech or a vote of thanks to read, but I'm just feeling so overwhelmed right now, and I'm just very emotional right now. So, when we started thinking about what is it that we wish to capture from an event like this, we were extremely particular about some things. One is that the event has to bring together all the color, flavors, voices from across the Northeast. We did not want to limit it to only Assam or only a certain organization or a group of people. So that was the first attempt on our part. The second attempt was to ensure that we have discussions around tribal health in a very holistic way, keeping in mind the unique identity of people, the cultures, the traditions, not disregarding any of those just because it's a health-related conference. And thirdly, non-communicable diseases is a topic that is very close to my heart, and all of us here are working for NCDs in some or the other way. We wanted to ensure that we bring in social determinants of health. We look at NCDs from a health system perspective, from a lived experience and a community perspective, and also from a non-health perspective through other sectors and through the eyes of other people who are not directly a part of health system or having lived experience of NCDs. So with this thought in mind, we conceptualized Jaagar and Awakening. And I think we are more than just awakened after 2 days of intense discussions on a wide variety of topics and a rich mix of speakers. I would take a moment and acknowledge our esteemed speakers. We started off the first day with an address by Dr. Shailendra. We spoke about what Piramal Foundation is, what it stands for, what is the work that we are doing in the Northeast region, and the context for this entire conference, which is what I shared with you just now. The welcome address by Mrs. Ida Nicolatsen, Senior Board Member from World Diabetes Foundation, also strengthened the context further as she spoke about why we need to focus on tribal health, health of indigenous people, which actually, although maybe constituting only 5% of the total poor, they are the 15% of the extremely poor population that we have today. We also heard about the work of state government, that is government of Assam. We heard about the work of Ministry of Tribal Affairs with respect to tribal health and also with respect to the work they're doing in collaboration with Ministry of Health and Family Welfare. The Seva Geet we played on first day made everybody's eyes moist, I'm sure. That is the principle of service which all of us try to bring in through our work across projects, across states, through Piramal Foundation. We also heard about work of World Diabetes Foundation globally and among indigenous populations in particular with respect to diabetes care, diabetes management, as well as prevention. Dr. Fohad then presented a very comprehensive picture of the NCD scenario in the Northeast. We looked at epidemiological factors related to non-communicable diseases, risk factors related to non-communicable diseases, and how these are spread across the Northeast region. We had glimpses from our work from the field. We played a song and we looked at how our district project coordinator from the WDF project working in the Mahasau district brought together the community and organized a program for people from the community with their engagement, with their ownership. I think discussions on traditional medicine and tribal healing practices by Dr. Imli Kumba were extremely insightful. It was a new subject, at least for me, but the way he presented it was simply beautiful. We released 2 ebooks, which were compilation of poems written by tribal children from Baksa and Mahasau. We also played videos from both the events. We had 2 really thought-provoking discussions on environmental health in relation to NCDs, that is with respect to climate change and with respect to changing cityscapes in NCDs and how spaces can be better utilized, how sustainability can be brought into our lifestyles, and how this has a bearing on the climate as well as on our health, that is in terms of NCDs in particular. And yesterday we ended the day with a beautiful session, a musical session, where we also learned about how music and de-addiction can be interconnected and how something like arts can be used for weaning people of addictive substances. Today was yet another insightful day. Our keynote speaker for the day, Dr. Ashok Roy, reflected on the NCD programs in Northeast, and he was also very kind enough to show us actual pictures and snippets from his experiences in the field, which was nothing less than eye-opening for us to see. And I think that was a very good strategic direction to the work of people who are engaged in NCD care, at least in the districts. We then looked at the work of Piramal Foundation. We looked at what is happening in Anamai, the Tribal Health Collaborative. We looked at the Digital Bharat Collaborative and the Aspirational District Collaborative. We also heard about the work in Saksham, which is a project especially for tea tribes of Assam in the tea tribe districts of Assam, focusing on maternal health. We then heard about how a peer support group and a lifestyle intervention program could help some people reverse diabetes. Of course, we only have the wider data as of now, and the main intervention data will come in soon. But we looked at how it is being done in Assam and early reflections from the same. We had e-launch of a game called Samiti, which is a game that we have specially designed to train Jan Arogya Samiti members in the state of Assam through the project Strengthening NCD Services in Assam, which is supported by WTF. We looked at what India Hypertension Control Initiative has done in the field of hypertension in Assam and Northeast. Then, of course, Dr. Kakoti, our program mentor, I can say, shared his reflections from clinical practice, stories from his clinical experiences of managing patients with diabetes. We reflected a little bit on importance of physical activity, what is happening in the overweight obesity space, and why we need to all come together and get ourselves moving and get the community also moving. Really brilliant discussions on gender and non-communicable diseases, including lived experiences of different persons. We also looked at some really insightful papers that were done in tea tribes of Assam, papers which looked at self-care practices and psychological distress among patients, NCD experiences from Meghalaya, and again, the traditional healing practices, use of self-help groups, and just whatnot. So I think we've had a very rich mix of discussions in these 2 days, and I can't thank everybody enough. So I would like to still make an attempt and thank whoever I can, starting with Government of Assam, of course, and World Diabetes Foundation for giving us an opportunity to organize an event like this and have all of you grace it with your online presence. I would like to thank all the team members that made this possible. We were working relentlessly in the background, and there were, despite minor technical glitches, I would say we managed to pull this off in a relatively short period of time. We had sleepless nights, and the way we have worked, oh my God, I just can't thank the team enough. And I think everybody has worked as if this is like a family event, as if this is like a family function, personal event for each one. So from my team, I would like to acknowledge all my team members. I'm taking the names in no specific order. I would say Talim, Jurismita, who's been a big support to me, but who is not here right now as she's on a maternity break. Manisha, Urmila, Utpal, Priyanka Das, Priyanka Bora, Himadri, Himashri, Diksha, Himanshu, Kamal, Ripen, Parikit, Pranjit, Priyanki, Zanme, Yasmina, Joydeep, Dibyo, Latashri, Moshabbar, Sadad, Iftikar, and also Karna, who is not here today. Madhu, of course, without whom this would not have been possible. I think we've really collaborated and how, so I'm extremely thankful to Madhu for his support in organizing this conference, in helping us brainstorm on it. And I don't think this would have been possible if not for Mr. Madhu Raghavendra's support. I would like to acknowledge the IT team, starting with Ramanaji, Krishna, Hitesh, the technical COE team that is helping us with knowledge and documentation, Dr. Devika, Shazia, Ranjana, Rahul, Tatha for guiding us on the knowledge part. The name Jaagar was in fact suggested by Tatha herself. Srinivas ji, who has designed most of the communication material that we showcased in this event, the banners, the posters, and I think we have actually made it work under very tight timelines and he has obliged. So I'm extremely grateful to him. We have our HR, we have our finance, all the participants who attended, all the speakers, and last but definitely not the least, our senior leaders who made this possible, Dr. Shailendra, Ashwin, who was here on both the days, and also Hardeep. So I would really like to acknowledge all our senior leaders for laying that trust upon us that we can go ahead and do this. The kind of freedom we got, karo, kuch nahi hota hai, karo, do it. I think that is very precious. It's very rare, and I'm so thankful to them. It's extremely fortunate to have such seniors in your organization and to also be there and back you up whenever it's needed. All the participants who made it, all the speakers who came. I am extremely sorry if I missed out anybody's name. I made all the chaos that was going on. I managed to put together a list, but if I did miss anybody's name, then I'm extremely sorry. I'm extremely grateful to everybody who I have worked with in the last few days, especially. And I would also like to thank the Almighty for and just for me, I am a very spiritual person, and I'm extremely grateful that we could pull this event off in a relatively short period of time over these 2 days, and that it is ending so beautifully. Thank you so much, each and every one of you. Thank you, all my colleagues from Piramal Foundation, for your immense support. Please fill in the feedback form and share your thoughts with us. Please write about us on social media. You can tag us and you can you can tag Piramal Swasthya. You can tag the World Diabetes Foundation. Please feel free to write about us also on social media. It will really mean a lot to us. So with this, I announce that the program has ended. Yes, from IT, it is Hitesh, Amol, Krish, and Krishna. Thank you, everybody. Yeah. Thank you so much. I'm seeing comments in the chat. Thank you, everybody. And also special thanks to Dr. Ashok Roy, because it was at a very short notice that I reached out to him, and he kindly obliged. This, I know he has like a very busy schedule. There's people coming from ministry and the parliament, and regional resource center is involved in so many things. But still, sir actually considered coming here. And not just, he could have just like said, okay, I'm coming for a very short time, but he accommodated this in his schedule. That really means a lot to all of us from the organization. Thank you so much, sir. I'm so grateful to you. And I think it was undoubtedly one of the best sessions from these 2 days. Thank you, everybody, and also not forgetting our partners from district. Everybody, I think a lot of people came and joined in between. Stakeholders from the district, from district NCD cells, the joint directors, or the district, the DCs as well as the DMs from the districts, and everybody, the district program coordinators, the DPMs, CHOs who joined program. I think it is you guys who made this program a success. Thank you so much. Thank you so much. So thank you. And I think with this, we conclude 2 sessions. We are live, by the way, we are live on YouTube. 2-day sessions are live on YouTube, and they will be there always. So if you have missed any session, if you feel that there's something really interesting which you could not attend because of your work, please feel free to go back on YouTube and watch it once again. Thank you.
Thank you,
so
Dr. Radha. Thank you very much. I listened all the topics. Thank you very much.
Thank you, sir. Really means
Thank
a
you.
lot. Thank you so much.